I'll just
Thank you
share
so
my
much
screen.
for our Indian colleagues and our Indian speakers for joining us. We have 10 eminent speakers and professors from India joining us with their very fruitful talks and very long experience. Our first speaker will be Professor John Mukhopadhyay from India. Will speak about an unusual tibial condyle fracture. Please, sir.
Can you see my presentation?
Yes, sir.
Okay, so just put it on full. Okay, so this is going to be a presentation of an unusual presentation of a tibial condyle fracture. So this was a 26-year-old male patient who had a road traffic accident 11 days ago. So he was turned over in his motorcycle. He doesn't remember exactly how he injured his knee, but he was unable to walk. He was seen in a clinic elsewhere and had a slab put on, and then he was referred to us, but he came 11 days after his injury. And that was the X-ray that he had when he was injured at his first site of presentation, and we repeated the X-ray, and that was what we had when we got the X-rays. So do we have any interactive session, or do we just continue?
No, sir, we can continue, sir.
Okay, so this was the presentation. So the unusual thing about this was that if you look at the lateral side of the condyle, it actually appears to be elevated rather than depressed. Now, almost every fracture that we hear about or read about or learn about, there's an element of depression, while here the condyle actually seems to be elevated compared to the opposite condyle. So that makes you suspicious of something going on there. Obviously, you will get a CT scan, and I will just run through the CT scans, the various sections and the reconstructs. So if you look very carefully at this particular one, which is a giveaway, if you see this line here, this is the cartilage line. So the fragment has actually flipped upside down, the lateral condyle fragment, so that the fracture surface is facing up while the articular surface is facing down. Okay. So the other CT scans, you can see there's the 3D. Again, you can see the fragment here with the 3D reconstruct, the whole big fragment where this is turned down. This is the articular side, and that is the fracture side. It also has a posteromedial fragment here and a further depression on the side posteriorly and a flip of the entire condyle on the lateral side. So we have to think about all this and then plan our surgery accordingly. So we looked at it and we studied the CTs, and then we decided that this was a situation where we had to start laterally to begin with, although he had a posteromedial fracture. So that was the approach. That is the condition of his skin. The swelling had settled down by then. He apparently had a lot of swelling when he initially presented to the earlier hospital, but this had settled down by then. This was the approach. And you can see that as we see the joint, you can see shining cartilage. So this is the tibial element. Here we've elevated the tensor, the sort of ITB band of the proximal tibia. And just as we're doing a submeniscal arthrotomy, you can see this fragment actually sticking out of here, turned upside down because the cartilage is on the inferior side. Okay, so that's the further sort of dissection, again showing the shiny side of the cartilage facing down. We actually had to gradually retrieve this fragment out of the joint because we had to flip it around to reduce it. So there's the fragment now outside the joint lying here. That's the gap here, the depression here. But this fragment would not fit in here until we had to further go down and actually move this fragment here. So there was a fracture here which had got depressed, and to get that in line with this, we had to actually elevate this fragment. So you can see that fracture here. We have to get the osteotomy there and then gradually elevate that fragment up. And then we had the gap into which we could fit in this fractured fragment and then close the gap. So there's the fragment being put back in. And then finally, everything's closed down. We put the iliotibial band over it. And then once we had done that, we could go ahead and put our fixation on the lateral side. And then we went to the postromedial aspect and put a small buttress plate on the postromedial side. So that was the post-op AP X-ray, which was done immediately post-op. And you can see now how this fragment has fitted back in. We've got these screws into this fragment, and this is the small plate buttressing the postromedial fragment. These are the AP and lateral X-rays post-operatively. So that was what we were able to achieve in this fracture. So now it was a question of getting him mobilized. So we started range of motion exercises just after the first dressing, which was on the second day, and the swelling had subsided. He was on the CPM machine, and we started him on just toe touch mobilization, no weight bearing, but toe touch mobilization. After about 4 weeks, he was partial weight bearing, and by about 3 months, he went on to full weight bearing, and he was making satisfactory progress. This was the situation here. This was him at 6 months post-op. You can see how the fracture is healed up all right. He's got a fairly good range of motion at this stage, not full range, but you can see he's almost able to squat, but not able to squat fully. So again, we continued with the exercises, and he had no pain. He was otherwise okay. And then when he came for his final follow-up recently at about 12 months post-op, you can see now he's able to squat fully. He's able to walk almost without a limp. And again, you can see the fractures healed. You may comment on a little bit of irregularity here, but on the whole, it's healed up quite well considering the type of fracture it was. He's got no deformity. His alignment is good. No flexion deformity, almost full range of flexion, and a pretty normal gait. So this was interesting. And so one of the reasons we were able to pick it up was because many years ago, I had seen a similar case. So this we are going back almost 18 years ago. This was in 2005. We had this patient present to us 3 months after the injury, okay? And he was treated in a cast initially with 4 weeks, followed by physiotherapy and mobilization exercises. And there was absolutely no movement. His knee was stuck in extension and just had a jog of motion. And this was the X-ray that he came to us with at 3 months. So that again, when we looked at this X-ray, you could see again here that the lateral condyle is actually elevated rather than depressed. Again, you can see the articular surface here and the fractured surface on this side. So because we had seen this case, we were actually anticipating the problem when we saw this case this time. So we did not fall into this problem of what they had done earlier, which was put it in a cast, thinking it was a relatively undisplaced lateral condyle fracture. And this patient came to us 3 months after his injury with almost only a jog of motion. And that was the CT scan that we did at that time. And again, you can see how the articular cartilage is here. And this was actually almost the entire condyle, the lateral condyle, which is flipped upside down. Slightly different from the case we had this on this occasion, where there was not the complete lateral condyle, but almost about 2/3 of the lateral condyle. This one had the entire lateral condyle flipped, and he also had a stiff knee at this stage. And then we went in and we dissected it out step by step. You can see how the entire lateral condyle with the meniscus still attached to it actually was stuck there in a position. And we had to then turn this whole thing around. We put in some wires. And at that stage, this was many years ago, we just put in screws. Then we put him on skeletal traction and started mobilizing his knee at that stage. And he went on very well, but fairly well. He did not come back for a follow-up. Unfortunately, he's from down many miles away, and he did not come back for a follow-up. Although we had one telephonic follow-up with him, where he said he was able to ride a bike, and then he had a second fracture of his femoral condyle, which he sent me the X-rays for where this fracture had healed, but the other fracture, the fresh fracture, needed surgery. So we asked him to come back, but he, I think, had surgery locally, but then we lost him to follow-up. But it was interesting because we had seen this case many years ago. That was the postoperative X-ray that we were able to achieve in that case with just 3 screws. We didn't put a plate at that stage. This was, as I said, in 2005. And then we had put him on skeletal traction and started his mobilization because he had a very stiff knee already there. So we wanted to mobilize him quickly. So considering that, he went on to heal well. And because we had seen this before, we were able to diagnose this particular case and treat it appropriately. And in this particular one, we have follow-up for a year now with a good result. So I think that is all that I have in my presentation. So I think basically you need to watch out for unusual presentations in any fracture that every time you think you've seen everything, you find something unusual which comes up with a different presentation. And some injuries just don't fit into the normal classification or patterns of fractures that we see. So you have to be aware of this. And if you find an apparent elevation of the condyle, think about a flipped fragment of the condyle, which may be responsible for this fragment being elevated rather than depressed, which would be the normal presentation that you see with a tibial condyle fracture. So I think with that, I will stop. And if there are any questions, would be happy to take them. I'll stop sharing with my screen. Thank you.
Thank you so much, Professor John, for this very interesting presentation. We are waiting for any discussion or any questions from our panelists, our speakers, our dear attendees.
Sure.
Any questions?
Has anyone actually seen something similar before? I think there's one Chinese report of a similar case which doesn't fit exactly the same pattern, but where they have reported that the fragment was flipped a little bit, but slightly different pattern again. But other than that, I've not actually seen any reports of this kind of presentation either. So if anyone has seen this, it would be interesting.
Any questions to Professor John? Okay, thank you so much, sir.
No, you're welcome. Thank you.
Thank you, sir. Thank you so much, sir.
There's a question, I think, in the question and answer box.
Yes. Yes, we have one question, sir.
Okay, so there were 2 questions, both about the meniscus.
The meniscus, yeah.
And there's one about whether I bone grafted
it. Did you
do
bone grafting, sir?
For the bone graft, no, because this was a fresh fracture and we were able to get the fragment back in place. And interestingly, this was, the meniscus was still intact in the, so the fragment had flipped over the meniscus. And once we got it out, we could actually put it back under the meniscus and the meniscus was okay. So we just did a suture of the lateral part of the meniscus. We didn't really have to do anything else to the meniscus. And that was the interesting part again in this case. Yeah. And in the other case that we had done earlier, the whole meniscus was with the fragment, which is interesting. Okay. And we didn't do bone graft. And I think nowadays we very rarely bone graft in proximal tibial fractures primarily.
Yes. Yes, I think we have no more questions. I think there is a question, another question.
In the chat, I'm not sure.
What about the neglected cases?
The mechanism of injury. Okay, so that is interesting because this is probably almost like a knee that probably half dislocated and came back with the fragment. I mean, it's interesting because the previous case had come 3 months later if it was difficult. But this guy had a motorcycle accident where he had quite a severe injury, but he doesn't quite remember exactly what happened. But it's a kind of a varus strain with probably hyperflexion at the same time. And this fragment broke and then just flipped over. So it's difficult to give a definite answer to that, but that's what I imagine what happened in that particular case.
Another question, sir, what about neglected cases more than 6 months?
On the medial side?
On the medial side,
yeah. So I haven't seen this on the medial side, but we see a lot of late presenting tibial condyle fractures with malunions, etc. And today, in the younger patients, we are doing a lot of intra-articular osteotomies. If it's a posteromedial fragment, we will do a osteotomy from the back, or sometimes we even do a medial epicondylar osteotomy to get access to the medial side, and then do an osteotomy, elevate it, bone graft it, and then fix it. So we've done some of these osteotomies as late as 3 years after the original injury in the young patients, where they have got fairly good results. So I think the knee, a lot of these intra-articular fractures which malunite, you can still salvage, especially in the younger patient.
Yes, we have another
But I haven't
question.
seen this exact pattern where it's flipped over on the medial side as well. So these are the only 2 cases we've seen in all these years.
Yes, sir. We have another question, sir. Look, flap rim fracture when you put the rim plate.
Yeah, so I think that was the best reduction we could achieve on the table. And that little bit of Stepho at the moment is totally asymptomatic. He's got a full range of motion. Interestingly, that little elevation is in the middle and not directly on the weight-bearing part. So hopefully it will not cause a problem. But of course, we need to watch him over a period of time to be able to be sure. We've got a year follow-up. He's fine at the moment. He's got back his range of motion, and he's got no symptoms, no pain at the moment. However, we would need a long-term follow-up to really say that he has no problems at all over a long term. Obviously, it would be a risk for early arthritis, but certainly he would have many years with this knee without a major problem. I would expect
another question, sir, that there was a little articular step off. Do you expect any consequences of this step?
Yes, so I think that's the question I just answered, was that, yes, you have to watch this. At the moment, he's asymptomatic, but you need to watch it for long term to really know if there's any early arthritis setting in the knee. Okay.
Yes, sir. Thank you so much, sir.
Thank you. It was a pleasure.
Thank you for joining us and for accepting our invitation, sir. Thank you so much.
It's my pleasure altogether.
Thank you, sir, so much.
Okay.
Our next speaker will be Professor Dilip Tanna. Professor Dilip will speak about functional junctional fractures of the lower limb. Professor Tanna.
Thank you. Can you see my slides?
Yes, sir. We can see it, sir.
So I'm talking about the junctional fractures, where the non-union rate is highest in the femur. I confine myself to the upper end of the femur and lower end of the femur, the junction between the upper 1/3 and lower 2/3, and junction between the upper 2/3 and lower 1/3. Junctional fractures of the femur, upper 1/4 and lower 3/4 femoral junction. These are the fractures where non-union rate is fairly high, and if needed, I'm talking about, the augmentation is an excellent way in which you can probably tide over the crisis. Only nailing in an unstable such comminuted fracture is not good enough. So on day one, I feel you should do this augmentation if you feel that this construct is unstable. Now you can see this is 5 months unstable construct, and this is never going to heal up. And you can see here in the lateral view, there is hardly any hold of the upper fragment. If you see such a thing, there is no point in really going through the thing. This is the one which went through the non-union, and ultimately it was treated with the augmentation plate, and this ultimately healed up very well. But you see this day one fracture, day one construct. In this sort of a day one construct, I'll augment this on day one because there is hardly any hold of the upper fragment there. The lower fragment is a reasonably good hold, but the upper fragment hold is not there. So such fractures, I feel, instead of waiting for the non-union and let 6 months pass by, when the patient suffers for 8 months, 9 months, or a year, it's much safer to do it on day one, augmentation things, and then it will be all right. Comminuted, I'm not talking about the transverse fracture, are unstable in only nail, more non-union chances. To overkill is not a sin in such fractures. As you can see here in such fractures on day one, if it is osteoporotic and all, you can do the augmentation and the fracture heals up and patient walks about on day one. Now this fracture, you can see if there is hardly any hold on to this fracture. On day one, if you do for such fractures, there is no point in just accepting this reduction. On day one, if you can do an augmentation, if you are stuck up, there is no harm. And I feel it is a very good way in which you can get away in such a bad situation. There is hardly any hold. You can see the upper end, hardly any hold in the upper end. Even the lower end also the hold is poor. Even if you make the nail thicker, upper end will not be able to really get a good bite of that. That's the reason I feel an day one augmentation would be a better option in such fractures when in doubt. Now this is an oblique fracture. Even if you nailed it, this is very unstable. Such an oblique fracture, even after nailing it, or even this is only one screw, but even 3-4 screws, if you put it, it's very unstable. And ultimately it needed an augmentation plate. Or a fracture like this, you put in the fracture, there is already a fracture which has occurred here. You put in the nail, this already has a fracture here, and ultimately this is going to go away. And there is hardly any hold because there is a comminuted fracture. This piece is separate, there is the gap here. So the proximal hold is very poor. And this is the one which happens, and you can treat them with this augmentation plate and super stability. You can make the patient walk about. Even though this is a negative reduction, good valgus is maintained because of the hook plate which I have put in there. And this is the one which I feel on day one, you shouldn't hesitate to put in this sort of a construct. Now I talk about upper 2/3 and lower 1/3 fracture. This is the fracture which is notorious for a non-healing, and particularly antegrade 2-screw fixation is absolutely contraindicated, I feel. And this is the one which, if you put an antegrade nail, you should augment it on day one. And this is the only way, because as you can see here, there is a big medullary cavity lower down. And this is the reason why it will not heal up. You can see the CT scan. You see the CT scan there, this nail has hardly any hold in the lower fragment. And that's the reason why these junctional fractures are very notorious for non-healing. Now, that's the reason people talk about it today, that instead of 2 screws, put in 4, 5, 6 screws lower down, which is a good option, which I agree. It is a better option than only 2 screws. So even these 3 screws which have been put in, this has also gone in for that. So the 4 screws is being recommended, but it's still not certain. So even this thing ultimately went in for a non-union and it needed an augmentation. The better option for this sort of a fracture is a distal femur nail. I've done a distal femur nail and you can see it is very stable at the end of the construct, even though it is not a big hole there in the lower fragment, but the screws which has been put in, this is the subchondral bone here. It ends up in a subchondral bone, and that is a very good hold on the lower fragment because of this tip, which is subchondral. So in a distal femur nail, in a subchondral, which is the biggest and the best fixation, which is enhanced by 3 to 4 screws in the distal fragment. This is the one which is a good option for that. But if in doubt, please don't hesitate and do anything, whatever you desire. So 3, 4 screws is a good option for this in a distal femur nail, and that is the one which is an option. Antegrade 2-screw fixation lower down is not a good option at all. Thus, a subchondral distal femur nail will work in junctional fractures, but not sure. So why not adjuvant plate when in doubt? Overkill is not a sin. Now you can see this sort of an oblique fracture, which the idea, the antegrade nail and put in the plate there on the same side. Patient start walking about and moving about on day one. without any hesitation at all. Or a fracture like this, long oblique fracture with a comminution there on day one, antegrade nail and a plate. I didn't want to do a nail from below, retrograde, because there is an osteoarthritis there. That's the reason I didn't choose a retrograde nail. So I did this, and as you can see, patient walks about, moves about, and the fracture consolidates and is fully healed up. Here is the patient. The joint replacement surgeon did this knee joint replacement. Can you see my slide? My slides are seen?
Yes,
No,
sir.
earlier slide only is seen, sir.
Yes,
Your
what I
slides are
felt. I
seen.
thought my internet is giving me trouble here. Just
Yeah,
a minute.
yeah. We can see that distal
can
third
see-
femur with the plating, augmentation plating at present.
Yeah, plate and nail.
Nail only.
I think we have lost him because his internet is.
With the
We can
total
see.
nail,
No, that X-ray is not seen, sir. We still see that nail with a plate.
Yeah.
sorry, I think I'll have to come back.
Okay, we are waiting for you, sir.
This I feel is not seen. I'll just come back.
Professor Tanna, you are still with us?
Tanna, sir. I think we have lost him.
Can we go to the next speaker, sir?
Yes, I am the
Will
next
he join?
speaker.
Okay, next speaker will be Dr. Shivashankar. Will speak about non-union of subtrochantric fracture with broken PFN. Sir, please. Thank you so much.
Can you see my slides?
Yes, sir.
Okay. Thank you, Professor.
Thank you so much for accepting our
And
invitation.
thank you for the invitation. I am the immediate past president of the Indian Orthopedic Association, a trauma specialist working in a tier 3 city in the state of Maharashtra. This is the case which I wanted to discuss. A subtrochantric fracture was treated with a dynamic hip screw or the sliding hip screw. As you can see, there is a interfragmentary screw or probably the screw through at the fracture site. But unfortunately, after a year, the fracture didn't heal and the implant broke. And that was the time the surgeon decided to treat this patient with a intramedullary nail in the form of proximal femoral nail. And this patient was doing quite well for 3 years. This is the surgery. Second surgery was done in 2014. And in 2017, this is the after 2 months X-ray, And in 2017, the patient came with a broken implant in this fashion. So as the fracture was not united, the nail didn't sustain the loads of the patient walking for 3 years, and it broke in due course of time. This was the time I was involved. The patient didn't come to my center, but I was called by the original surgeon who had operated this patient earlier. And I did this surgery in his place. You can see there is a huge gap posteriorly. After the implants were removed, there was a huge gap posteriorly. What I did was I used two K-wires to prevent the nail going through the same track, so that to make the entry much more medial, I passed two antero-posterior K-wires, and I also passed one anti-version guide wire that will give, since I was operating on a lateral position in a simple table, this K-wire gives me direction of the neck, so that if I keep my jig parallel to this, doing the neck interlocking with the neck screw will be easier without much radiation. So with this, I pass this anti-version guide wire in the anterior part of the neck, and I pass two K-wires lateral to the entry site in the proximal fragment. And I could insert the nail, and I applied plate. And as you can see, there was a lot of gap here. I applied bone graft also in the same place. Here you can see there is a screw here. This screw prevents the nail going again laterally. This is the screw which is preventing, because the nail entry was taken earlier from the tip of the trochanter. I tried to medialize more by going more on the medial side of the neck. Again, due to the track which was there laterally, the nail could have gone more laterally. So to prevent that, I put a blocking screw lateral to the nail, which is seen here as an anteroposterior screw. And this is the immediate postoperative picture. This is the nailing. This is the augmentation plate. There is a lot of bone graft which has been applied in this patient. And he came only once for follow-up. And I tried to get his follow-up. I tried to contact him 2018, 19, 20, 21. So many times I tried to contact him. Finally, I could get his mobile number through one of his earlier records through the earlier hospital. And once I tried to contact him, he didn't come to me. Practically, it was a very near place, just about 20 kilometers from my place. So our hospital staff went and brought him to the hospital, and I took the X-ray at that time. This is after 4.5 years, because you can see that we had not seen him earlier. This is directly after 2 months he came. After 4.5 months, 4.5 years, the fracture has beautifully consolidated. The earlier entry was from the tip of the trochanter. This I've tried to medialize by putting a blocking screw, and the fracture consolidated beautifully. And this is the clinical picture. This is the picture of the earlier surgery, the next surgery, and the patient was able to do all the activity. Unfortunately, because of the 3 surgeries he had a shortening. You can see that he's lurching on the right side where I have operated, because of almost 1 inch of shortening he has got. But he was able to do all the activity without any trouble. And you can see that there is a shortening of 1 inch on the side we have operated because of the multiple surgeries done. And the lurching could be due to either shortening. Also, a lot of bone graft has been obtained in the earlier 2 surgeries from that side. So that also could have caused some problem with the muscles attached there. And anyway, all is good, which ends up well. And as Dr. Tanna was talking just now, at junctional area, especially non-union, it requires absolute stability. Absolute stability can be given only by plating. It cannot be given by nail or anything else. So if you are treating a subtrochantric fracture or a lower third femur fracture, it's better to put if you are a nailer like me, it's better to augment the nailing with a local plate. The plate can be spring plate or a wave plate, or it can be a solid plate also. And you can see that the nail can give stability over a longer duration of longer length of time, length of the whole bone. So the nail gives long stability and plate gives near stability, because absolute stability can be given by only the plate. Nothing. If you are doing only nail, it doesn't give absolute stability, especially in non-union cases. It's better to do plating also as an augmentation plate. This is another case. Again, this patient was walking on the implant for 10 years and he sustained a fracture of the implant and because of the non-union, as you can see. Since the entry has been from the tip of the trochanter, you can see that the inferior screw, though it is in the inferior part of the neck, it has gone into the center of the head. The varus was the one which is culprit here in this case. So what I did was, this is the earlier entry side. This is the tip of the trochanter. This is the neck you can see. And this was the earlier nail entry side. So I took an entry much more medially. How I took it? I applied a Steinmann pin. I prevented the my entry going again to the earlier entry by applying a anteroposterior Steinmann pin. Then I did the nailing. I did everything. I did the freshening of the bone ends because it's 10-year-old non-union. Then I did the shingling of the bone. I did the exchange nailing. I added bone graft. I added augmentation plate. So these are some of the pictures. I am removing the broken implant in this picture. Now you can see, but I am holding the fracture and I am trying to ream the bone. And also I am doing the shingling. You can see my sharp osteotomy is shingling the osteoperiosteal flap around the bone. And this is the picture which shows that I'm making a canal and there is an anteroposterior K-wire which is preventing the lateralization of the entry side. And there is also another K-wire here which is giving me the direction of the neck in the lateral view. So that when the jig comes after inserting the nail, so this gives me a fair idea about the direction of the neck. So at the end, you can see I have applied a proximal femoral nail. These are the two neck screws. This is the augmentation plate I have done. I have also done the bone grafting in this patient. And this patient, which had the fracture which had not united for 10 months, you can see here there is a lateral. I removed the K-wire and inserted a anteroposterior blocking screw so that the nail will not go to the earlier track. That is the reason why I have passed this. Here you can see the screw which is lateral to the nail. This earlier entry was from the tip of the trochanter. Now you can see that I have taken the entry almost from the piriformis fossa and the fracture united within about 4 months time. The patient did all the activities beautifully without any trouble. This is the video just at 4 months time. He was walking comfortably and I have subsequently removed the implant also. I thought I will be presenting one case, so I didn't include the final pictures. But here are some more pictures of similar cases which I'll rush through. This was a case subtrochantric fracture which was treated with a regular femur nail. The fracture broke, the implant broke. The surgeon decided to only remove the proximal portion of the nail. I ended up doing the next part of plate augmentation with nailing with PFN and the fracture consolidated, as you can see. Another proximal third femur fracture. I don't say that it is a subtrochantric fracture, but it is a proximal third femur fracture. Again, you can see that the fracture has gone into non-union and the implant failure. This is immediate post-operative X-ray. You can see that beautifully the fracture has been reduced. Nail has been inserted again from the piriformis fossa medial to the tip of the trochanter. The alignment is good. The calcar screw, the cervical screw is inferior both in the neck as well as in the head, indicating that there is a good valgus. I have added good amount of bone grafting, and this is just at 8 months follow-up when the patient had come. This also case I had done outside, so I don't have the long-term follow-up, but you can see that the fracture had united without any problem at this stage. This child was operated at a young age when he had a fracture in the femur where the plating was done. He came with a subtrochantric fracture. We removed the implant and applied a locking plate. Unfortunately, that locking plate broke in due course of time. As you can see, there was a gap. For a young patient, locking plate, I am not convinced. Unfortunately, because of the market-driven forces, somebody had used this locking plate at the time, and the fracture didn't allow collapse. The plate didn't allow collapse, and the fracture broke in due course of time. This was the time I was involved. I can see that again in this case, we have done nailing again from the piriformis fossa. I am reiterating again and again. all the problems in the proximal femur is due to entry which gets lateralized. If you take an entry from the tip of the trochanter and the bone is weaker on the lateral side, your entry gets lateralized. So always try to take an entry from the medial to the tip of the trochanter or even from the piriformis fossa. So then you can be in line with the middle canal, and you can see that the fracture consolidated in due course of time. This is 1 year later with a beautiful consolidation of the fracture, and this is the function of the same patient at this time. So these are some of the cases I wanted to show. This is one, probably the last case I'm showing, a subtrochantric fracture. It's not an implant failure, it's a non-union. Again, you can see that I have used the same technique of nail with augmentation plate, and the fracture has consolidated. Friends, non-union requires absolute stability, which can be given by only by plating with compression. So if you are a nailer like me, I am the past president of, there is a subspecialty in India, National Association of Interlocking Surgeons, the acronym NAILS, National Association of Interlocking Surgeons. So I am one of the past president and founder of this association. So I like to do nailing or a keyhole surgery. So if you are also nailer like me, you can augment the nailing with local augmentation plate. I normally tend to use spring plate or wave plate, especially if I'm using for a shaft, I use a spring plate. Spring plate is something like a bent like a C, so that I can do graft globally. The wave plate is also same. You can do graft globally, or sometime in a subtrochanteric region where I want to get stronger plate, I use radius ulna plate or a mini DCP plate. In that, it is difficult to bend it to a wave plate. So I use a straight plate in such cases. So nail gives long log stability, that is over the whole length of the bone, and plate gives absolute stability by decreasing the working length of the bone. Thank you very much. Over to you, sir.
Thank you so much, sir, for this very interesting presentation. We are waiting for any questions.
There are not much question. If you have any question, you can ask me, or if any other panelist has a question, they can ask me.
If any one of our panelists has a question.
My question to you, do you do this such non-union with this technique? My question to you, Professor Mohammed.
Yes, sir, please. I'm sorry.
No, my question to you, and since nobody is asking any question to me, let me ask a question.
We have a question to you, sir.
Okay.
Do you roll out infection before revision?
I didn't get you.
Do you roll out infection before revision?
Definitely. The infection has to be ruled out, but all these cases were non-infected one, which I have shown. Yes, I do have cases where it was infection, where I have first controlled the infection by putting stimulant bead or antibiotic coated nails. Then subsequently, I have treated them with a similar fashion. I have not included in my presentation in this presentation.
Yes, sir. When do you decide, sir, to go to external fixation?
Non-union requires absolute stability. I don't think external fixation is a good option. Yeah. If there is no infection, yes, I do put a nail and an external fixator in the form of like Elizero and compress. This is usually in the humerus, not in lower limb. Or I can do the same in tibia also, but I'm not comfortable in doing subtrochantric area. So I preferably use external fixator only in upper limb. With a humerus nail, I do put a ring above and a ring below, especially in humeral fracture, which has gone into non-union. But subtrochantric fracture, I think I'm totally against putting external fixator because it's really cumbersome for the patient.
Yes, in some literature, sir, when we found infection, we can put a custom-made nail from cement impregnated with antibiotics, such like the spacer. Exactly. Correct. Do you prefer this technique, sir?
Yes, definitely. I do prefer it. Even I do get, since I'm in private practice, I do get patients which come after 10 days or 15 days with infection pouring and the fracture not treated properly, or treated initially with external fixator, but infection has not been taken care. In such cases, I primarily use interlocking nail. I have designed a nail. Interlocking can be done, and you can also add antibiotic coating on that. So
Yes.
I use primary antibiotic coated interlocking nail in such cases.
Yes, sir. We have some questions from our attendees. First question, would you primarily put augmented plate if you anticipate non-union, sir?
No, primarily I don't put
prophylactic?
it because I don't want to open a fracture. See, basically you are losing the fracture hematoma, the advantage of the hematoma in fracture union. So I depend more on the initial stability. Very rarely, yes, comminuted fracture in young adults, I put a augmentation plate, especially in distal third femur, but not in the proximal third femur.
Yes, sir. We have a question from Dr. Ahmed Morsi. In the case revised by proximal femoral locked plate, when the patient can start weight bearing, sir?
I almost always allow all my patients weight bearing immediately with partial weight bearing with the help of walker. I give them walker and ask them to, I give them a bathroom weighing machine. I show them how much weight to put. Normally, I ask them to put about 25% of the weight in initial 2 to 3 weeks time. After 3 weeks time, I ask them to put about 50% of the body weight. Then by about 6 weeks time, all of them will be walking full weight bearing with the help of walker. By about 2 months time, they will be totally off the walker.
Yes, sir. Do you use grafting routinely, sir?
I didn't get you, sir, please.
Do you use grafting, bone graft routinely?
Grafting, no. Grafting, I reserve it for only non-union cases. Primary, I don't do it. See, if you are operating 100 cases, only 1 or 2 patients will be requiring grafting. So other patients, if you are doing grafting, it's unnecessary. You are additionally morbidity you are giving to the patient. So I normally prefer doing grafting only as a secondary procedure, not as a primary procedure. Yes, in a non-union cases, I might little treat, over treat, even in a normal non-union or little hypertrophic non-union also, I don't mind putting a graft because I don't want to take a chance again. I should be the last purchase if I'm doing a revision surgery. This, with that intention, I might over treat with grafting. But primarily, no, I'm not from the school of primary bone grafting.
Yes, sir. There are a question from Dr. Muhammad asking if there are early post-operative signs of AVN, any concerns in the entry point of intramedullary nail?
AVN is problematic with a piriformis fossa entry only in younger patients. The non-union usually doesn't happen in younger patients. Non-union happens in adults and elderly people. So entry over the piriformis fossa, I have never faced a problem. I routinely take any femur nail, whether it is proximal femur nail, any fracture of the femur, I routinely take a piriformis fossa entry. I have been promoting in India because the problem of going little more laterally from the tip of the trochanter is the proximal fragment goes into varus. Once it goes into varus, the non-union problem is very high. You can see that, I mean, almost all the cases I showed, the entry was from the tip of the trochanter. As the implant manufacturer say that the entry has to be from the tip of the trochanter. If you take an entry from the tip of the trochanter, the screw, though it will be in the inferior part of the neck, it will go in the superior part of the head or middle part of the head. So the head goes into varus. Because of the varus vector force, these fractures go into non-union, implant failure and other things. So I have not faced any problem by taking an entry from the piriformis fossa.
And the same question from Dr. Sandeep, why would they get greater trochanter entry so often? And I think you have answered it, sir.
Yes.
Another question, retrograde nail for subtrochantric, any difference in the results versus antegrade nail, especially in certain cases?
I think for retrograde nailing, we should reserve only for distal femoral fractures,
Yes.
not for proximal femoral fractures.
Yes. The last question, sir, if there is shortening, what's the solution?
I think we can either lengthen the tibia because it's easier to lengthen tibia with a LA0. We have got good LA systems available. So I don't think or even if it is less than half an inch, with just a shoe raise is also sufficient. But if it is more than half an inch, I think better to lengthen the tibia. But unfortunately, our patients in the part where I practice in India, they don't accept. The surgery is the last resort, they accept it. Only when nothing can be done. So for cosmetic purpose, for lengthening purpose, they don't come to me for lengthening.
Yes. Thank you so much, sir, for this very interesting presentation.
Thank you very much, sir. Thank you.
Thank you, sir. I don't know if Dr. Dilip Tanna is with us again, or he is has a technical problem.
I don't think he is not there. He is not there.
Has mailed and said he has a technical problem.
Okay,
Because I
thank you
just
so
saw
much,
the
sir.
mail. I think it is 21:45. I think. Thank you, sir. We're
Yes,
going
sir.
to go into a little bit of spine now.
Yes, you are the next speaker, sir.
Yes, sir. I'm Dr. Surya Prakash Rao from Hyderabad. Let me share my screen.
Thank you so
Just a
much, sir.
minute. Just a minute, sir. Let me share my screen.
Hyderabad, there was the SICO, I think there about maybe 6 years ago or 8 years ago in Hyderabad.
Yeah, CCOT we had
The
conducted.
CCOT was there, sir. It was in
Yeah.
a big way in Hyderabad.
Yeah, it was a big event there.
Yeah. Sir, can I start?
Yes, please, sir.
Yeah, this is because I never thought that we are going to discuss a lot of case series, because one Dr. KBS Srinivas told me, he said, present one case. So, but then if retrospectively, I feel had I known this, I would have made a big detailed presentation on this, because I have so many cases like this. But nevertheless, I'll just go through this interesting case of a post-traumatic vertebral non-union. Now, this is about a story of a woman who is 68 years old. She has a trivial trauma at home 8 weeks back. That is the day from the day she has presented to me. She was locally diagnosed as a T12 compression fracture, and routinely, as in orthopedic practice, a lot of people advise brace, rest, analgesics, and most of them, because it's a small wedge compression fracture, they say it will heal well conservatively, and they sort of in some scenarios, they don't even allow her to get up and go to toilet. They say, no, everything should be on the bed. Some sort of a severe restrictive regimens in some scenarios it is followed. But in this case, I think she was managed reasonably okay. She was given a brace and she was just about up and about after 3 to 4 weeks, but she had no relief even after 8 weeks. That's when she came to me. On presentation, she had severe pain. And the typical history she gave is unable to change the position from lying down position to getting up. And in bed, after sort of lying down for a while, she's not able to turn on either side. And severe pain, and this is impacting the activities of daily living. Fortunately, she is neurologically intact. Now, these are the radiographs which they came to us. And you can see this non-union here at a fracture at this level with lot of collapse of this. This is, and she has an incidental degenerative spondylolisthesis at this level also. And then we immediately got an MRI scan to just check what is happening. And you can see in the sagittal view, you can see the sort of a Comel sign opening up nicely. It's collection of fluid into the vertebral body. And fortunately, there is not much of a sort of a canal or a cord compromise. And otherwise, she is neurologically preserved. Then when we get this flexion extension views, hello, am I with you? Yeah, when you see the flexion extension view, you see the thing opening up nicely, a sort of a Kumel sign, what we call it. Mostly this is a vertebral non-union, which is probably secondary to some sort of a phenomena, which most of us are not sure. It is mostly a sort of a necrosis of the bone, and then the bone stops healing. And these people are prone for further collapse, further kyphosis, and in severe cases, there can be retropulsion, and further trauma can lead to neurological deficit. Now, in this seminar, everybody was talking about osteosynthesis, but here we are looking at other options beyond osteosynthesis. We we can consider doing a standalone vertebroplasty in her, or a standalone kyphoplasty, or we can augment the above procedures with the help of a posterior spinal instrumentation or simple bone grafting, but many with posterior instrumentation. But many a times bone grafting through transpedicular doesn't really hold very good, especially in non-unions. In fact, if anybody wants to do a significant good sort of a stabilization, one has to go transthoracic and put a nice stud graft in the front, which becomes too much an aggressive surgery for a 68-year-old lady. So we chose to do a kyphoplasty in her. And here in kyphoplasty, we sort of place the patient in prone position. And then as soon as we put the patient in position, you see the opening of beautifully the thing is opened. Then we just go through the sequences of the procedure, how we do. We sort of use the, guide wires. After the guide wire, we put in the working portal, then the balloon inside, inflate the balloon. Once we had the inflation of the balloon, then we have the entire thing coming up nicely, and then we fill it up with bone cement. So this particular procedure gives a beautiful outcomes, and though it is done through one pedicle, it spreads on either side nicely, and then we can see a beautiful, filling up of the vertebra. And these patients have almost instant relief of pain, and we would be they'll be very grateful that within few hours after the procedure, they would get up and walk, and they would carry on with the daily activities. However, being an artificial bone cement in a normal spine, we just need to be worried about the adjacent segments. Sometimes this can be a stress raiser on the adjacent segments, and we have to do a bone marrow, bone density evaluation. And if we find significant osteoporosis, she needs to go for a teriparatide injection for a few months, and to ensure that all the deficiencies are taken care of. And I think this is a small case, and thank you very much for the time, sir.
Thank you so much, sir. We are waiting for any questions to Professor Sorai. I think we have one question, sir, asking about, is this the initial X-ray at the time of the fracture?
Initial X-ray, what I presented was when she came to me after 6 weeks, not the first X-ray after injury. It was the X-ray after she came to me. That was the X-ray taken in my clinic.
And what about the neurology in such a case, sir?
Usually, unless there is a canal compromise, there is no neurology. If there is a canal compromise, then they usually have a neurology. In fact, at this segment, even 10 to 20% of canal compromise, patients usually do not present with neurology. And any situations where there is a gradual compression, the spinal cord is resistant to the developing neurology. Most of the times, neurology happens in a sudden or a situation where there is a sudden sort of a jerk or an injury, and there is a sort of an insult to the dura.
Yes, sir. Dr. Walid is asking, sir, is kyphoplasty a sufficient option in this high stress zone?
Kyphoplasty is a very good option, especially when treating these non-unions. The safety of kyphoplasty is far better than in vertebroplasty, because vertebroplasty and kyphoplasty differ in two important methods. In a vertebroplasty, we just insert the needle and try to push the cement with force. Then it can take any pathway, whatever it wants, and it can sort of get into the breach and then cause or can extravasate into the spinal canal and cause neurological deficits or problems. But in a kyphoplasty, as I showed you in the short video, it's a situation where we create a nice controlled space with the help of a balloon, and the cement is delivered under no pressure whatsoever. So that way, the entire the cavity is compacted, and in the compact cavity, the cement sits. So kyphoplasty is very good because it restores the height, and also at the same time, it reduces the risk of cement leakage dramatically.
Yes. I
Professor
think
Harsh,
it's a
can I
very
ask
big
you a
problem,
question?
the cement leakage, sir.
Yes, cement leakage chances are much less with kyphoplasty than vertebroplasty.
Yes. Professor Hisham, you want to ask a question, sir? Professor Hisham Farhood? Okay, we have another question, sir. Would you consider a cage and a bone graft in addition to the posterior stabilization?
Those options would be for a younger patient. Suppose if the same thing happens in a 45 or a 50-year-old, then that would be my option. At a 68-year-old with a osteoporotic vertebral non-union, the faster, the less invasive and less, morbid the procedure, the better are the outcome. The beauty of this procedure is that even if I do a kyphoplasty, suppose God forbid this fails, I have those options still available to me in the future. I am not burning any bridges.
Yes, sir. We have two of our attendees raising their hands. Can you please write your question in the question and answer box, please? Yes, we have a question, sir. Cause of pre-existing pathology, osteoporosis only?
Yes, sir. Most of the times, these Kummel signs and these non-unions are due to osteoporotic pathology only. The beauty of the kyphoplasty procedure is, as we do the initial steps of inserting the needle, we have an adequate provision of taking some bone from there and sending it for biopsy as well. So in these clear-cut cases, we generally do not send. But in case of any suspicion, we always take a biopsy before we do this.
Yes, I have a question for myself, sir, please. What's the precautions and the prerequisites you should have to avoid the cement leakage, because this can end in a disaster?
I did not get the question, sir. Can you please repeat?
What's the precautions you do, sir, so you can avoid the cement leakage, because this may end in a disaster, the cement leakage?
Absolutely. Few things. One, the procedure of kyphoplasty is fairly safe when as we expand the balloon and create a nice cavity in which the cement can be deposited. That is one. Two is the cement is delivered at lowest pressure through a plunger which displaces the cement through the cannula. And three, we wait until the cement becomes into a toothpaste consistency, where as we push the cement out of the syringe, it sort of folds onto itself instead of dropping down. That would be the correct time where we have to insert the cement. With these precautions, we usually can reduce the risk of leakages to a maximum.
We have a question from Professor Hisham Farhood. He is an Egyptian professor specialized in spinal surgery. Why you consider this fracture is non-union?
Whenever we consider it a non-union, because most of the osteoporotic wedge compression fractures heal within 6 to 8 weeks. If beyond 8 weeks, we see the cleft and we see the intervertebral instability, that is, there is an instability in flexion and extension view, where we see the mouth of the vertebra opening up and closing, then we see the Kummel sign, we obviously know the vertebra has not healed by this time, and it is unlikely to heal if you wait in the future. That's why we call it non-union.
Yes, sir. Thank you so much for this interesting presentation, Dr. Surya. Thank you so much, sir.
Thank you, sir. Thank you so much. I will unshare my screen. Yeah, I've already answered.
Thank you, sir. Thank you so much, sir. Our next speaker will be Dr. Venkatarmanna from India, speaking about intercondylar fracture of the humerus, fixation without olecranon osteotomy. Thank you so much.
Good evening, and thank you, Professor. I'd like to share my slides. Please see. Are you seeing? Are you seeing my slides, Professor?
Yes, sir.
Distal humerus fractures are a challenging but rewarding injuries to manage. Advances in plate design and surgical technique have improved the outcome of internal fixation, which is the current standard of treatment. However, the procedure can be challenging and a high rate of complications. Sometimes use total elbow arthroplasty as a treatment option in elderly patients and in a difficult fracture where we cannot reconstruct the fracture. Thorough understanding of the complex anatomy of the elbow, the soft tissue stabilizing structures around the elbow, and the adjacent neurovascular structures is essential before doing surgery around the elbow. Distal humerus is a triangular lateral column and medial column. They are together tied by the articular fragment with a tie arch. The articular segment of the distal humerus is anteriorly angulated around 30 to 40 degrees and a valgus of 6 to 8 degrees, and the internal rotated about 3 to 8 degrees. Whenever you're going to go for before surgery of the elbow, you have to thoroughly evaluate whether the fracture is open or closed or the adjacent neurovascular structures are involved or not. Next. Our treatment goals are getting a articular congruity, are you with me, sir?
Yes, sir.
Our treatment goal should be restoring the articular congruity, re-establishing the anatomic and mechanical axis, achieving the stability so that you can allow the unrestricted elbow range of motion almost immediately. Non-operative treatment is only for non-displaced fractures, and whenever there is a comminution in a severely debilitated patients where they are not fit for surgery. There are several surgical approaches. One is lateral approach only for exclusively for lateral condyle fractures, and the posterior approach for all types of distal humerus fractures. Even in posterior approaches, I use mostly triceps sparing approach. I use in lateral decubitus with hand hanging over the support. Posterior, midline posterior approach, and the triceps is separated from the lateral and medial intermuscular septum. I excise the medial intermuscular septum after isolating the ulnar nerve and securing it. Through the intermuscular septum, I can feel the anterior condyle by finger, and most of the reductions I do under CM imaging sphere control. Sometimes we need olecranon osteotomy when the fracture comminution is big and we cannot do a proper reduction by doing without triceps sparing approach, but it is rare. Despite olecranon osteotomy, 40% of the anterior surface remain unvisualized, and osteotomy carries the risk of non-union, future need for removal of metalwork, and potentially limiting any future arthroplasty. Hence, I do osteotomy only when absolutely necessary. See, when I am doing this triceps sparing without olecranon osteotomy, my idea is first to reduce the columns in a three-dimensional way and check by CM imaging sphere and palpating with your finger both anteriorly and on all sides, and then stabilize them by doing a initial K-wire fixation. After reducing the columns, they automatically the intra-articular fractures will fall in alignment because the intact olecranon acts as a mold on which the fragments will be molded. So once we got the fracture reduction, the fracture fixation, we have to follow all the principles of the word Driscoll. Whenever you have articular fragments, intercondylar interfragment fixation, we can use 1 or 2 lag screws, but we have to avoid over compression or segment when there is a comminution. So first restore the columns, then reattach the atlas bases to diaphysis, and lag screws or neutration plate, compression plate, and bridge plate. Several plates will be used to do that job. Next. So plate position, I mostly use 1990 plating of Jupiter. Plate choice, medial side to contour that, we may many cases I can manage with reconstruction plate, but posterior lateral plate, I use a stronger plate, either a LC-DCP or anatomical plate. Indication for LCP is whenever the fragments are small and the bone is osteoporotic and there is significant comminution of the columns. Bone grafting I use for columns when there is a comminution and gap, but we should not use graft in the olecranon fossa because it may cause some stiffness in later. Osteotomy repair should be done properly, otherwise it will go into problems of non-union. Ulnar nerve, mostly I don't do anterior transposition. I secure the nerve while doing surgery. We can get good results with wire of plating, but it has some problems of hardware pain, the plate and becoming prominent over the subcutaneous area of the elbow. Complication of non-union as itself are uncommon because it's a very metaphyseal bone and highly vascular bone. Unless there is gross comminution and a fixation problem with the fixation and problem with the bone quality, non-union is rare. But we can manage non-union very well by doing a revision plating and bone grafting like this. So we're going to the case example, 36 male with a right hand dominance. There is a distal humerus fracture extending into the intercondylar area associated with dislocation of the capitellum. Even such fracture can be very well reduced without doing olecranon osteotomy by triceps sparing approach. You see, this is a 3 months follow-up, getting full range of movements. And if you notice, there is a displaced fragment of bone anteriorly. Even that displaced fragment doesn't come in the way of movements if you do thorough physiotherapy. That fragment will absorb over the period of time. Another example, a badly comminuted fracture fixed by another surgeon by doing olecranon osteotomy. Fortunately, the reduction is good, but the plate he has used is a insufficiently strong, less strong plate. So because over the time that plate failed, and again he applied a posterior plate, even that failed. So this case, I did a anatomical LCP plating and bone grafting, and he got a good fracture union and good movements. Another case, distal humerus fractures with intercondylar fracture in a young female who is an endocrinologist by profession. This is also done by triceps sparing approach and anatomical locking plating was done. So another bad case done by triceps sparing approach. And here I have used additional K-wire support for the bone with just by reconstruction plate, both posterior lateral and medial. After even 4 years follow-up is very good. The plates are still holding good and with good union. Another case, very badly comminuted fracture. So very well fixed by reconstruction plates, and I have used K-wire for additional support. Another bad distal comminuted fracture, very well fixed. Even you can see the very good reduction of the intercondylar fracture without olecranon osteotomy. So sometimes you face a difficult fractures, very badly comminuted with loss of bone. We can do total elbow replacement primarily. Here in this is an example of Bakshi's elbow replacement. Very good movements and a good follow-up of 18 years. Suppose when you see a patients like this, a total loss of bone in even elbow is lost. You need a custom-made elbow to save the limb and movements of the boy. So thorough evaluation is essential for going for surgery. Understanding the anatomy and it should play an important role in giving good results. And most of the fractures can be fixed without olecranon osteotomy. Very rarely I use olecranon osteotomy. Articular reduction and stable fixation and early physiotherapy are essential for good results. Most of the intercondylar fractures of distal humerus can be managed without olecranon osteotomy, avoiding the risks associated with it like nonunion and implant prominence. Even without olecranon osteotomy, with triceps sparing approach, we can spare the anconeus. It is a secondary posterolateral stabilizer because we are not disturbing the triceps attachment to the olecranon. We can allow early movements so that patient can get post-operatively very good range of movements. Thank you, sir. Ready to take any questions.
Thank you so much, sir. I think we will have many questions in this very interesting case. First question, if you allow from me, sir, the last case, sir, you have presented and you have done for her total elbow replacement. She was, as you said, 18 years old and with osteoporosis. What's the reason?
No osteoporosis. This is a badly comminuted fracture. And if there is a gross osteoporosis in elderly patients also, we can do elbow replacement. That's what I told.
Okay, she do not have osteoporosis, but she looks like to be in a younger age group.
There is the loss of bone. That's why I did a replacement.
Yeah.
Due to accident, trauma.
It was not amenable for fixation, sir.
Yes, yes.
Because she's too young, I think, for total elbow replacement.
I understand, but there is a loss of bone. We cannot restore the condyles and diaphysis.
Yes, sir. Yes, sir. We have some questions, sir. First question, sir, what are your options of management for low supracondylar fracture with intercondylar extension?
So that's what I have discussed. I can do without osteotomy with triceps sparing.
Yes, sir. Another question, sir. What's your physiotherapy protocol? Would you recommend immobilization early post-operative?
Very early, immediately when the pain is subsided. Even 1 or 2 days, I will allow physiotherapy.
Yes, sir. Will olecranon osteotomy changes the post-operative protocol of physiotherapy? I think, of course, yes.
Yes, yes.
Yes. Another question, sir. When do you prefer to do primary arthroplasty rather than fixation? Is age would be the main factor after labor solution?
Age is the main factor which they cannot, and the bone structure, that means very osteoporotic bone, very soft bone, very cannot hold the implants, then we'll go for arthroplasty.
Yes, sir. Another question from Dr. Najwa. What's the absolute indication of olecranon osteotomy, or when we should do the olecranon osteotomy, sir?
Especially what I follow is, first initially I do triceps sparing approach, and I try to do very good reduction with the help of CM image intensifier and different manipulations and finger palpation anteriorly. If I don't get a satisfied reduction, then I will go for olecranon osteotomy.
Yes, sir. We have another question from Dr. Ahmed. Professor Venn, are you going to change the elbow replacement for the pediatric patient in the future with a larger size?
No, I don't do a replacement.
I think this is not a pediatric patient.
Yes.
Yes. This is not a pediatric patient.
Yeah, I don't do a replacement for a pediatric patient.
Of course, sir, of course. Another question from Dr. Hani Mansi. Two plates have the same height, increase stress riser on the distal humerus.
Yeah, definitely. I don't keep on the same height. I will see the height is a little variation from lateral and medial plates.
Yes, sir. I think we have another question. Yes. does the patient understand that the revision rate is high and will need this in the future? I think the revision rate in the total elbow.
Yeah,
We
yeah,
have
yeah.
no other option.
Definitely, there is no other option. Then only we
Yeah.
are doing a replacement after explaining the patient.
Yes, sir. I think we have no other questions. What about the triceps tongue approach? You don't prefer it, sir?
What is that? Triceps tongue? I don't have experience in it.
Yes, sir. Yes, sir. And if you are obliged to do olecranon osteotomy, you do a transverse osteotomy or chevron osteotomy?
Chevron. I prefer chevron.
Yes, sir. Thank you so much, sir. Thank you so much
Thank
for
you.
your
Thank you very much, Mohammed, for
and for
giving me the
accepting our invitation. I think we have the last question, sir. I'm so sorry.
Yeah, no problem.
Does the patient understand that the revision rate is high? That's we can do arthrodesis for the child in hopeless cases. She's asking about if we can substitute the arthroplasty with a prosthesis, with a arthrodesis.
No.
For
most of the pediatric patients where you cannot fix a fracture, they will very well tolerate the conservative management and ask them to do physiotherapy once the pain subsides. Just like a bag of bone technique, they will have good range of movements and reasonable stability. No need for joint replacement in children.
Yes, sir. Thank you so much, sir. Thank you so much.
Right, sir. Thank you.
Thank you, sir. Our next speaker is Professor Devnendra Agraharam. Will speak about small wounds should never be neglected. This is a very important topic, sir.
Good evening to all of you. Is my screen visible, sir?
Yes, sir.
Yeah. I'm going to talk about the open injuries with small wounds. We need to expect the unexpected complications when we see small wounds in open fractures. Commonly, we see these two kinds of open injuries: a small wound with a simple fracture, a large wound with a gross comminuted fracture. And most of the times, a grossly comminuted fracture with larger wounds, they take quick attention and then get treated in a different track. And smaller wounds, most of the times, they get neglected. So the small wounds with extensive comminution or bone loss or muscle damage is very important. It is very deceptive term to say that it is a small wound. Small wound or large wound both needs to be considered in the similar fashion, because there will be an extensive skin deglowing, crushing of underlying muscles, extensive bony comminution with loss, and there can be contamination and injury to the neurovascular structures. Let me share a case where an young individual who met with an accident and presented to us in the casualty at around 11 o'clock in the night. He had a ilium fracture on one side and forearm fracture along with open elbow. That is a 3 centimeters wound, horizontal wound in the posterior aspect of the elbow, just above the olecranon. And on arrival, the lactate was serum lactate estimation showed above 5, and blood sugar was quite high, which tells us that patient is having uncontrolled diabetes mellitus. And in these situations, when the patient arrives in shock and in the middle of the night, sometimes smaller wounds gets neglected. That is what has happened, and this wound was just superficially debrided, and then suturing was done. And 48 hours later, when we took him up for a second look debridement, by the time he got resuscitated and the sugars were a little bit less, ketones were negative, and lactate also is normalized. However, we can see that there is extensive crushing of the muscles, avulsion of triceps from the olecranon, and gross contamination, both medially and laterally. So these kind of extensive soft tissue disruption through a small wound, we don't appreciate many times. So this gets missed. So here it took almost 1.5 hours for the debridement. And then once we are completely satisfied with the debridement, there was a dilemma whether to put an axonal fixator and wait and do, or straight away go ahead for plate fixation. Since it is a upper limb injury with open injury and adequately debrided, we went ahead to do a plate fixation, and at the time of second look debridement, these are the C-arm and X-ray images. And 5 days later, we can see that there is a infection, purulent collection coming from the suture line. And immediately the next day, we have debrided opened and debrided the wound. There was a lot of infection, and debridement was thoroughly done, and then started him on linezolid and amikacin for a week period, followed by oral linezolid for a 3 weeks time. Culture report shows gram-negative bacilli growth as well. And after 2 months also, still the infection is persisting. Even though it is not actively discharging, there is a sinus with minimal discharge, and we can see that the X-ray at the end of 2 months shows there is a dense sclerosis of the bone near the joint region, and intercondylar extension fracture alone looks healing. Apart from that, there is a periosteal reaction with osteolysis around the plate as well. So when we took him up for a debridement at the end of 2 months, this is how it has come out along with the plate. The whole sequestrum, around 6 centimeters of sequestrum came off from the operated site. And this is how we were left over at the end of debridement. There is around 8 centimeters approximately the bone defect. And at this stage, we were thinking to add external fixator. But however, if we add the pins, there is a possibility of pin tract infection again, and we might lose future fixation points if we apply the external fixator. So we have left him with above elbow slab, and we waited for some time, almost 6 weeks time. And this is the X-ray at the end of 6 weeks, where there is a bone defect with minimal periosteal reaction also we can see. And at this stage, once the infection is completely controlled, there is a bone loss in the upper limb. We had the options of taking either tricortical iliac crest, which can be used only for up to 6 centimeters, and vascularized fibula. There are advantages and disadvantages of vascularized fibula, because we need to have a good setup with a microsurgery team, experienced team, so that the success rate will be very high. So we have a very good plastic surgery team with us who does microsurgery procedures. So we chose vascularized fibula. It was harvested from the left leg with a skin island and vascular pedicle. And this is the fibula, which we break into 2 by taking a small half. Still the vascularity is intact, both proximally and distally. And then we try to curve it and place in the defect, and dual plating was done. This is how it was planned in the defect. Medial column, completely it is stabilized, and lateral column, the small bone that is left over, it is fixed to the shaft, and then dual plating was done. And this is at the end of 1 month and 5 months X-ray, where both proximally and distally the fibula is uniting with the host bone. And this is at the end of 1 year, where it has completely healed without any much problem. Initially, since there was a lot of crushing of soft tissues, we expected some stiffness, and he had stiffness. He required quite a long time physiotherapy, and he got reasonably good range of movements. And now he is able to eat on his own and drive the vehicles and routine work, even though there is a residual fixed flexion deformity, and not terminal range of movements are restricted. Coming to the one more case, where a 41 years old gentleman presents with a small open wound and around just above the patella, with the bone protruding through the wound, and there is a comminution at the distal femur fracture site with intra-articular extension. We can see that there is extensive gas shadow extending up to the mid shaft level, which tells us that the whole bone has come out through the open wound, and then soft tissue also is crushed, and periosteal stripping has happened, and the outside air is being sucked. So this is a very important sign that we need to understand. And during debridement, we need to extend higher up to the mid shaft level where the soft tissue stripping has happened. Otherwise, this can go on to have a serious complications with infections. So this happens, even though the wound is small, this negative suction effect at the momentary negative suction effect that occurs at the time of injury sucks out all the surrounding dirt, whatever is left over on the road, and then even gas, air also gets sucked into the bone intramedullary also. So it is very important not to reduce the bone if it is protruding through the open wound. We should not reduce the wound, bone in the casualty. Always take him up for early debridement, and then after adequate debridement, put the bone inside. So here, if we look look at the pathophysiology, the small wound that happens when the moving object comes and hits the limb with the knee inflection, the wound is small and the bone protrudes out. And then when the violence continues, sometimes even the long segment of bone also gets ejected out. This is how is the mechanism of injury that happens and bone loss occurs. So the principles of debridement remains the same irrespective of the size of the wound. So here we can see the left side picture where the wound has been, the open wound is included in the debridement, and then it is extended higher up, completely up to the mid shaft, and then surrounding contaminants, crushed muscles, everything was removed, intramedullary contaminants were removed, and loosely lying cortical segments are also removed. And we can see that there is some amount of bone loss. However, on day one, it is easy to do articular reduction, and articular fracture reduction was done, and external fixator was applied. And our Ganga Hospital open injury severity score was 10, which tells us that we have to stage the procedures for this kind of major injuries. And once the patient is fit for next procedure, once there is no infection at the end of 5 days, we have taken up for definitive fixation. And we can see that there is a bone graft also added at the fracture site since there is a bone loss. Primary bone grafting also can be done routinely in open injuries, provided we debride the wound adequately. And these are the limb alignment pictures. And we can see that the fracture alignment is good. And at the end of 15 months, we can see that the fracture has completely healed. And even though the small wound with extensive soft tissue stripping and crushing, we can see that patient is able to achieve a good range of movements, and he is able to do all his activities. So to conclude, small wounds should not be neglected. Small wounds with extensive comminution and muscle injury has to be taken care adequately as we give attention to the larger wounds. They are not just Gustloff-Anderson type 2 injuries. It is more than that. So we need to give equally good attention to the smaller wounds since higher complication rate is possible, and we may need to do multiple secondary procedures if we neglect this kind of open wounds with small open wounds. Thank you.
Thank you so much, sir, for this very important presentation about a very important topic. We are waiting for any questions to Professor Devendra. My first question, sir, in the last case you have presented, do you use the less invasive stabilization system for putting such a longer plate?
Yeah. Yes, sir.
Yes, sir. We have a question to you, sir. How many liter of
yeah, I saw the question, sir. I mean, what is the amount of fluid that we use to clean the open wound?
Oh, yeah, to wash it, yeah.
Yeah, initially the 15 years ago, the evidence was like for type 1 open 3 liters, type 2 6 liters, and type 3 9 liters, like that the saline we need to use to wash. But now it doesn't it is not important for the amount of fluid that we use to wash. It is the adequacy of the debridement that we do by removing the contaminants. So adequate debridement is more important than the amount of fluid. Amount of fluid can be you can use even 1 liter also if you have thoroughly debrided the wound. So debridement is the key compared to the amount of fluid that we use to wash.
Yes, sir. Do you use, sir, topical antibiotic in the wound after washing out?
No, sir. Again, the answer is same. The adequacy of the debridement matters more than using local antibiotics or any other method. So debridement is the key. No local antibiotics we use routinely.
Yes.
It is not required, sir.
Yes, sir. And some surgeons in the last years used to do very good debridement and internal fixation if the wound is after debridement is clear, and they put a prophylactic septobal beads of antibiotics. You do not recommend this, sir?
No, evidence says that we don't need to routinely use topical antibiotics or local antibiotic beads. They have to be restricted to only the infections, because we are delivering the antibiotics directly to the open injury site. And debride, even if you give tons and tons of antibiotics, if you don't debride the wound, again it is possible that it may go for infection.
Yes, sir.
So debridement makes the difference rather than looking at antibiotic delivery to the open injury site.
Yes, sir. I'm sorry, sir. We have many questions because it's a very important topic.
Yeah, no problem, sir. Please.
Sir, small wounds could be a large soft tissue stripping that why we classify intraoperatively. Would you consider X-Fax in from the beginning in elbow case?
Sorry, sir, I didn't get you.
The small wound could be a large soft tissue stripping that why we classify intraoperatively. Would you consider X-Fax in from the beginning in the elbow case?
Yeah, I think day one it should have been thoroughly debrided, and then if you find that there is a lot of contamination inside the wound, you can stabilize it with external fixator. Again, come back after 48 hours, do a second look debridement, and then go for definitive fixation. Yes, external fixation also is a important this one, sir.
Yes, sir. Another question from Dr. Muhammad Zaki. What's the rule of cerclage in the case of lower femur?
Sorry, sir?
What's the rule of cerclage wiring in the case of lower femur fracture?
Yeah, they're all positional wires, sir. They're just to keep the fragments in position when they are scattered around the open injury site with soft tissue attachment. When you have soft tissue attachment, if you leave them lying scattered in the thigh, they may not participate in bone healing. Sometimes if you want to get a good alignment, positional wires also are helpful.
Yes, sir. Another question from Dr. Sandeep. Sir, how long could we wait for such small wound before definitive fixation? I mean, when are they expected to get infected if they are not seriously cleaned or deprived?
No, we need to be as early as possible to do debridement, but definitive fixation, you can wait even up to 2 weeks also. If there is no infection, then you can go ahead to do. We wait up to even 2 weeks if there is a lot of contamination on day one.
Yes, sir. Another question from Dr. Ayman Abu Tawila. I think you have answered it, sir. How long period between debridement and permanent fixation?
Yeah, that depends. Like sometimes if the patient requires bone grafting and extensive procedures, we have to make sure that there is no infection. So we can give up to 2 weeks time also. We wait up to 2 weeks time and then do the procedure. Even sometimes in major open injuries, we wait up to even 3 weeks also.
Yes, another question from Dr. Abdullah. What's the best to do after tibial infected tibial nonunion, which fixed by intramedullary nail, please?
If there is infection with intramedullary nail, it is always better that we remove the nail and debride the intramedullary region outside everything, and then go for external fixator. Like you can choose orthofix, uniplanar system, or circular ring fixator also, Elizero.
Yes, sir. Which classification for the upper limb?
Yeah, open injuries, commonly everybody uses Gustilo Anderson. Our Ganga Hospital open injury score, we use it for mainly the lower limb tibia fracture. And we do extend the same classification for upper limb also, so that we get a good idea of what is happening in this one. So MES score and Gustilo Anderson score is fine.
Yes, sir. We have another two questions in the chat box. Do you use cement? Do you use cement after debridement? I think he is asking about muscular knee.
Yeah.
Maybe.
No, when there is a bone defect, if you want to do bone grafting, if you are planning to do bone grafting after some time, like not primary, maybe after 6 weeks or 2 months time, then you can fill the defect so that the defect doesn't get covered again with the fibrous tissue. The future dissection will be easy, and then easily we can bone graft it. So small defects you can put cement and then remove after 6 weeks time to bone graft it. And in infections, definitely yes, we do use cement, but not routinely like a cement beads. When there is only bone defect, we use cement.
I think we have no more questions, sir.
Yeah.
Thank you so much for this very interesting presentation about a very important topic, sir. Thank you so much, sir.
Thank you, sir.
Thank you, sir. Our next speaker will be Professor Vivek Trikha from India, 3-month-old fracture dislocation of the proximal humerus. Professor Vivek. Professor Vivek, you are with us, sir? Yes, we can see your presentation, sir.
And you can hear me?
Right. Yes, sir.
Thank you. Thank you so much.
Thank you, sir.
I'll be presenting a case on neglected proximal humerus fracture dislocation, a case. We know that in India and in other developing world, neglected injuries are quite common for us to deal with. And this literature is not evident in the worldwide evidences which are available. So what are the modalities by which we can manage these cases? That's what we are going to discuss over the next 10 to 15 minutes. I'll be presenting this case of a polytrauma who unfortunately was in some hospital for an ICU for his dorsal spine fracture, which was fixed somewhere. And he came to us after 3 months with this fracture. You can see what happened, that he was having pain. And whenever he was showing and telling that he was having pain, people said that it is because of the dorsal spine fracture, which has been fixed. In spite of being in a medical hospital, he was, and this fracture got neglected. The chest x-rays were there, and the chest x-rays were showing the rib cages and not going right up to the proximal humerus. And hence, this fracture got missed. And 3 months later, he comes to us with a fracture, which is like this, a fracture dislocation of proximal humerus. We got the CT scans done. And this is the CT scan, which you can see. If you see the scans, there is all the fractures, the humeral head is broken, the GT and the greater tuberosity is separate. The head has gone posteriorly. And if you see the third and the fourth films, 2D as well as the 3-dimensional ones, you can see that there is a lot of callus formation which has happened over a period of 90 days. You can see that the callus is there, especially under bone formation in the proximal part of the humerus has happened. So the question which comes now is where we are. It's a 90 days old fracture. The person who is there is a 40-year-old patient having a 4-part fracture dislocation of the humerus. He's a bus driver in an Indian capital city of a transport corporation and has to do heavy works which are there. And what are the possibilities which are available for us? Are we going for a replacement or we are going for a reconstruction? And this is a very common phenomena which happens in cases of fracture dislocation of proximal humerus, whether we are going to go in for a proximal replacement or a reconstruction in a young man. Most of these are in young high velocity injuries in young productive age group. And how do we achieve good results in a 40-year-old male? The questions which come are, if we are going to salvage this, what is going to be our approach? Whether we are going for a deltopectoral or a posterior separate approach or a mid-deltoid approach. How are we going to reduce? What are the tips and tricks which can we use for this reduction part? What will happen to the bone loss which has happened over a period of 90 days? And do we keep any backups as well while we are managing such cases? So these things need to be looked for and discussed. And I hope that we will have some questions regarding this once we have finished with this case. The choice of treatment, what we opted for in a 40-year-old patient was for head salvage and reconstruction because of his dominance, because of his work pattern which he was doing, and he wanted to continue in his work. His profession was such. The fragment size, you could see. One thing which was helpful for me and to decide was the fragment size. If you see the proximal humeral head size, it was quite a big chunk of the two, greater tuberosity as well as the proximal humerus head. And that made me think of a possibility of a salvage for him. And with the working in our trauma center at New Delhi, with our experience with open reduction and fixation of these fractures, we had a fairly good idea of managing such cases till 1 month, 45 days, but we had to extend it for 90 days here. This is the thing which we had published also in Journal of Shoulder Elbow Surgery, where we had a retrospective analysis of fracture dislocation cases, which we had managed with salvage and fixations. And what suggested that out of our 33 cases, majority of them had good results, provided the age was less than 50 to 55. The 3 failures which we had were mostly in the borderline areas of 55 years, where a possibility and the avascular necrosis happened. But in the young, most of the cases, we were able to manage these cases without any great morbidity to the patient. So the strategy which we used was a part of the diamond concept, which Peter Giannidis has so well espoused, regarding adequate stability, osteoconductive and osteogenetic potential needs to be brought about, along with man-made or natural growth factors which can be added. So you need some osteoconductive scaffold, you need some osteogenic potential and the growth factors, and also give mechanical stability and the environment so that the things can unite. So going back to our old case, original case, the deltopectoral approach is the standard approach which I use even for my posterior dislocation cases, as well as for my interior fractures. A lot of callus and granulation tissue was observed, which was natural and which was obviously we had anticipated that. And since we were not able to identify the things, the first thing which we did was to osteotomize the lesser tuberosity here. Because the lesser tuberosity was malunited in a specific position to the humeral shaft or the rough area. And it was not possible to go into the glenoid posteriorly and visualize that humeral head and bring it back. So the first thing which we did was osteotomizing the lesser tuberosity, holding it with the ethibond, as you can see on this picture, and then going about opening up the glenoid cavity and then trying to hinge out. The greater tuberosity was also tagged, which we had done. And then the humeral head, which was lying posteriorly, was slowly and slowly brought out, which was hinging on the posterior aspect of the glenoid with the periosteal hinge or the homans, by hinging it and reducing it by leveraging at the level of the posterior glenoid. If it wouldn't have happened, we would have used a shank spin or some 2 homans to elicit that fragment from posterior to anterior. So we were able to bring the humeral head from the posterior side to the anterior. And then the critical thing which I feel in proximal humeral fractures is to maintain the medial continuity or the calcar continuity, which is very important to get this back and to get the outcomes. For the bone loss and the gap which we had, we repositioned the greater tuberosity, and before that, we put in an intramedullary fibular strut. This was an autogenous fibula taken from the patient's body, but it was non-vascularized. It was purely used as a fibular intramedullary strut, which will be holding the humeral head with the amount of bone loss which has happened to give some support to the shaft and the humeral head. And then the callus which was there had been nibbled out, was put back onto the positions to be used as a bone graft. Then the K-wires which were used to maintain the arch as well as to maintain the neck shaft angle of the humeral head were done properly. And once we are able to get this with the continuity of the medial calcar, which is the most important thing, then subsequently a Phylos plate, standard Phylos plate was added to him, a 3-hole plate was added. In the end, since the lesser tuberosity which was there has been in the center picture, you can see it was lesser tuberosity which was osteotomized, was fixed back with a screw as well as the ethibond. And since the groove of the biceps tendon had become quite rough and was uneven, to avoid postoperative pain, the tenodesis of the long head of biceps was done here. As you can see in the final picture, the position of the Phylos plate is at right place. The calcar screws have been put, fibular strut is there, and a lesser tuberosity has been fixed back with a screw as well as ethibonds, maintaining the medial calcar continuity. This is the post-op image. And we were quite happy thinking that we have been able to bring back the position of the head as per the Hertel's criteria. Also, we were hopeful that this may work properly. This is his 3 months follow-up, where we started doing about his range of motion and muscle strengthening exercises after 3 months. And you can see that he was able to do quite good range of motion. You can even see the dorsal spine scar of his dorsal spine fixation, which was done and which had initially led to this missing of this fractured frat. This is his 6 months follow-up. And now you can very well see that the position of the head has remained at the place. The neck shaft has been maintained, and the screws, calcar screws, as well as the fibular strut out there is now getting incorporated, and the solidity to the fixation is being given. And this is his final follow-up at 2 years of follow-up, where you can see that the vascularity of the femoral head is maintained. And as you can see that he has got full range of motion, full abduction, full rotations, and he has gone back to his work of his factory, whichever the transport work which he was doing. So many things similarly of this dislocation. I'll just take one more case like this, showing you an anterior dislocation, another very small anatomical head, 4-part fracture dislocation anteriorly now, managed similarly in a young patient of 30-year-old. But here, instead of putting in a fibular graft, we have used an iliac crest tricortical graft with a small anatomical head, maintaining the shaft and neck angle properly. And this is his follow-up at 3 years, 5 years, and at 6 years follow-up. Along with 8 years follow-up, you can see that there has happened mild sectoral avascular necrosis, but the patient is okay. His functional outcomes are excellent, and he's able to do all his activities. So I would say that in take-home for proximal humerus fracture dislocations are complex injuries. However, most young of the patients and the young patients who get these injuries can achieve good functional outcome after fixation, maintaining the head and the shaft angle, maintaining the medial cortical continuity, and fixing back the tuberosities well to the head will bring you back a good range of motion, meticulous surgical dissection, stable construction, and early physiotherapy, which is quite aggressive and improves over a period of 3 to 6 months, are cornerstones to achieve a satisfactory outcome. Thank you for your patient listening.
Thank you so much, Professor Vivek, for this very interesting presentation. I think we have many questions for you, sir.
Yeah.
Can
please.
I start with a question, sir? In such a case of neglected fracture dislocation, do you routinely use investigations such as MRI or isotopic scan to check if there is any early signs of AVN in the humeral head?
I might be using them in the borderline cases, as our study also showed, which we had done, which showed that most of these cases may have not the best of the results if the patient's age in Indian setting is above 55. Then you have to be slightly worried about that. And then you can decide whether you want to salvage, along with consultation with the patient, whether you really want to salvage it or replace it. But with our experience in our literature, and there have been subsequent evidence also in the world literature, which suggests that in young patients who are less than 50, and with the present day implants which are available and the technology as well as the thought process which is there, we should be able to salvage this head. The avascularity, even if it happens in proximal humerus, may not be that debilitating and morbidity wise as compared to a femoral head. Because the sectoral avascular necrosis, as I showed you in my last case, it was a small anatomical head. We fixed it around 2011, I fixed it. And now it's now 12 years that it still is working. Patient's X-ray might show a mild sectoral avascular necrosis, but the patient's functional outcome ultimately is complete and he's having good results. So MRI only in cases where the outcomes may be doubtful, which is in borderline cases or elderly patients. In young cases, until unless it's a comminuted fracture altogether with multiple parts, all efforts should be made for salvage.
Yes, sir. And if you suspect AVN, sir, do you prefer to use the fibular graft, vascularized fibular graft?
You can use it, but I don't have that technical expertise in my hospital where I'll be using that. And I feel to get that in a proximal humerus might be quite a challenging thing to do that. So, but since I haven't have any experience for that, we feel that providing good stability, good neck shaft angle, and maintaining the medial calcar continuity, that's the most important thing, which gives you the prevention of failure of the head, which goes into VARS.
Yes, sir. We have another question from Dr. Fahd. Do you follow Hertel criteria to predict about the humeral head ischemia?
Yes, in my paper also we had contentions regarding Hertel's criteria. And if you see the Hertel's paper as well subsequently, which he published in 2006 and subsequently in 2014 as well, the other authors who published, you can use the Hertel's criteria as a preliminary guideline to get the prognosis, but it cannot be sacrosanct that if it is an anatomical head, you cannot go in for a reconstruction and you cannot salvage the head. And this was even admitted and agreed upon by the original authors as well, which we also had published in our paper like this.
Yes, Dr. Muhammad is asking about the post-operative regimen and when to start, sir.
Yeah, so that's the most, exactly. That's very important because it's not the X-ray picture which is important for the patient, it's the functional outcome which he is going to get. And the functional outcome is purely based on the physiotherapy post-operative. I'm very aggressive regarding my physiotherapy in the sense that the next day onwards, the pendulum exercises will be started. The patient will be having passive active assisted exercises with the arm being assisted by the opposite side of limb up to 90 degrees of abduction and flexion. The second thing is after 6 weeks to 2 months, till that time, he's going to continue on this. Then once you see a check film, which is showing you evidence of bone formation and the union process, which is starting to happen, then you start them on active exercises, which is along with the walls, with the rotations and abductions, circumductions. And after 2 months, you start the rotations. And subsequently, you are going in once the fracture has united after 3 months for the active muscle strengthening exercises, which gives them the full range of motion. Remember that the motion continues to improve up to 6 months. Don't just get disheartened up to 3 months. Make sure that you are able to encourage your patients because the movements will increase if the patient is motivated enough to get movements up to 6 months.
Yes, sir. I'm sorry, Professor Vivek, we have many questions, if you allow us.
Sure, please. I'm very
Yeah,
willing
Dr.
to
Ablatif
answer.
is asking when to decide to do coracoid process osteotomy, and based on which criteria do you decide the graft choice?
The graft choice. Okay. So the first thing is the various tips and tricks to reduce the anterior dislocation of which is fracture dislocation is one of them is coracoid osteotomy. However, for me, I haven't done a coracoid osteotomy till date in my more than 50 odd cases which we have done, even in late. Just last month, we had a case which was around 60 days old, but we still did not do, because what we need to understand is if you are able to relax the muscles, you might be able to bring out the thing. So what I always do is make sure that my shoulder is flexed as well as my elbow is flexed, which gives and relaxes my biceps and the muscles which are originating from the coracoid, below which my head has gone. So once you are able to relax the muscles which are above that head, you will be able to tweeze out that head slowly and slowly from there. However, if you feel it has gone quite medially, coracoid osteotomy can be done, and it is a well-described procedure. As regards the choice of graft, if I find that the medial calcar is mildly comminuted, I might like to put in a tricortical graft there, making it as a wedge in the medullary shaft and fixing my humeral head onto it. However, if I find that my humeral head is also small and my graft positions may not be able to hold my humeral head to that, these are the places where I use a fibular strut, making it slightly pointed so that it can get indented into the proximal humerus part fragment, and which gets it as a support.
Yes, sir. We have another question from Dr. Mudaffar Ahmed. Professor Vivek,
Sure.
any kind of soft tissue reconstruction have been done? And is there instability during the follow-up?
Yeah, that's a great question, because we had a similar question as a letter to editor for our paper as well. And we found, and we have subsequently quite followed up, I feel that if you are able to reduce it with a soft tissue mobilization in a proper manner, we didn't have any instability because of the anterior glenoid erosion which can happen. We were quite expecting it in a 60-day-old fracture, which we operated 4 weeks back as well. But it didn't happen once you were able to bring back your proper greater tuberosity and lesser tuberosity. However, as a precaution, after fixation, you should always check for instability. And if the anterior labrum or the anterior glenoid has got eroded, you can, and it's very well described, that you can go take out that coracoid and fix your, just like in a Latarjet procedure, can be done if you want to do it. However, in our 50 or more than cases, and in neglected cases as well, we didn't have any opportunity or any requirement of doing such thing.
Yes, sir. Another question from Dr. Abdulatif. What's your best files plate placement criteria? Surgical set indications or fluoroscopy?
I didn't get, sir. Which is
what's your best files plate placement criteria? Surgical set indications or fluoroscopy?
It is a combination of everything where it has to go. You have to ensure that it is at least 1 centimeter lateral to your bicipital groove. That's the first thing. And based on that, you can even go slightly more laterally if you have a greater tuberosity. Regarding the top portion, you always look at the fluoroscopy to make sure that you are not going too high up. Again, it's around 8 millimeters down, so that your anterior impingement or the impingement does not happen when it is getting abduction. But I feel after that, ensure in Indian population, sometimes the humeral bone morphology is small. So many a times your top screws and the calcar screws may not even go also. So they also give you, I put in some K-wires in the proximal and the distal calcar to ensure that my plate placement is ideal, and it is going right into the screw fixation also is going into the humeral head. So I think it's more of a combination of everything.
Yes, sir. We have another question from Dr. Walid Goma. How can we avoid the axillary nerve?
Okay. So as a matter of fact, for any deltopectoral approach which you are doing, and once you are trying to mobilize the deltoid, which is from the lateral aspect, with your finger with the blunt dissection, which you do, and see your greater tuberosity, at that time you need always to pass your hand and the fingers over that sling into the inner part of the deltoid, where you will find a string-like structure along with the vessel, which is the axillary nerve. So you always check for axillary nerve on the lateral side whenever you are giving an abduction and mobilizing your greater tuberosity and below it. You cannot do much at that time if it is broken, but it's usually not torn anyway. Most of the 99%, you will never ever find that axillary nerve is going to be damaged. Yes, in callus formation, sometimes it can get difficult, but thankfully the callus is not formed so down. It is around 7 centimeters down. So the greater tuberosities and all, they are higher up, and you are not going to have much problems, but you need to do blunt dissection sometimes to ensure that it is not entangled anywhere.
Another question, sir. Tips and tricks for reconstruction of the lesser tuberosity and the subscapularis.
Okay, so if it is, make sure that you are having your ethibonds ready all the time. I would always say that proximal humerus reduction and fixation is more a soft tissue surgery than a bony surgery. You need to ensure that your tuberosities are fixed back to the plate or to the humeral head as good as possible. I always tie up my lesser and the greater tuberosities with ethibonds. Even if one of them is not broken, I manage and make sure that they are at the osteotendinous junctions so that you don't go through the bone or through the muscle. Osteotendinous junction will be the area where you should fiber hold of the sutures should be, and fix those sutures to themselves as well as to the plate, because that is what is going to give you good stability both from anterior and the posterior aspect and help you in post-operative mobilization.
Yes, sir. Another question from Dr. Muhammad. Sir, how would you explain the patient not having early AVN with such a fracture with less than 8 millimeter calcar?
Yes, and that's the reason why we contended Hertel's criteria in our paper. Because if you start following Hertel's criteria word by word, then no fracture dislocation, which is a 4-part, can be operated and salvaged. You will have to replace all of them. But you see in life and in nature, there are things which happens, and there are a lot of vascularities which are coming from some areas which we are not so properly defining, which will give you back the vascularity. Moreover, the stability which you get by good fixation and putting in the grafts and the strut grafts, they help to give the creeping substitution and making sure that even if avascularity is happening, it can be circumvented and taken care by the newer vascularization which happens because of good stability which is there.
Professor Vivek, can we have more questions or that's enough?
It's up to you, not to me.
We have 4 questions more. Can
okay, we'll just, yeah, sure.
Yes, sir.
Sir.
Thank
no,
you.
No
do you do biceps tenodesis routinely, sir?
No, I do not do them. I'm very particular. I try that biceps is not a vestigial organ or a tendon. It needs to maintain its position of the stabilizer unless your groove and the place in the rotator interval that has got a lot of irregularities and you are not being able to maintain it back in any fracture. I would not like to tenodese it, because if it is rough and the groove is not proper where it has to its excursion is not going to happen properly, then it might lead to pain. Those are the only cases where I will do a biceps tenodesis. Otherwise, I like to preserve the biceps.
Yes, sir. Sir, another question from Dr. Aziz Botros. Why you did osteotomy for the lesser tuberosity?
Yes, because this fracture fragment was lying posteriorly. It was a posterior fracture dislocation. My lesser tuberosity was the first thing which I was seeing from my deltopectoral approach, which I normally take for this. And hence, to enhance my visualization of the glenoid, which, because it was a delayed case of 90, the lesser tuberosity had malunited to the soft tissues and the structures there. So I had to osteotomize it to remove it, to get an exposure of the glenoid and subsequently go posterior to it to remove my femoral head. That's why.
Yes, sir. Another question from Dr. Amir Sheikh. What about intramedullary cage in such cases?
Yes, sir. You can use the cages as well if you are there, and you can use small amount and thinner cages. In India, we are much more conversant with autogenous fibular grafts, which we have been using. You can also use allografts if you have available of the fibula. They will also be done. I am much more conversant with autogenous fibula. That's why we have used them. But cages, small cages, thin diameter cages can also be used.
Yes, we have another question about the subscapular stenotomy. I think you have answered it, sir. Last question for me, please, from Dr. Abdulatif. When to decide that the fracture failure and when to pass to arthroplasty for young patients?
Young patients, as a trauma surgeon, I would like to fix it all the time if possible. But you should know your limitations, that if your head fragments are more than 3 or 4 or 3 fragments, then maybe you may have to go in for the replacement straight away. Sometimes it is crushed massively. As I said, my indication of managing this case by salvage was a big chunk of humeral fragment, head fragment, and a big chunk of greater tuberosity, which made me go back for a salvage procedure. However, if the humeral head is shattered, then that might be one of the more common reasons where I will go for replacement, or it's an eggshell in elderly patient.
Yes, sir. The last question, sir, from me. It will be from me. If this case did not unite, do you prefer to do hemiarthroplasty or reverse shoulder?
In 40 years, I'll still like to go with a platform type of hemiarthroplasty so that I can convert it later.
I prefer the same, sir. Yeah.
Thank you, sir.
Thank you so much, sir. Very interesting case. Thank you so much,
Thank
sir.
you.
Many thanks to Professor Vivek, and sorry for the very long question, sir.
No issues. Thank you so
much. Thank you so much, sir. Now we go to the next speaker. Next speaker will be Professor Abhijit Wahingkur. Oh, Dr. Abhijit, how are you, sir? Second time to meet you.
Well, thank you. Yep.
Thank you so much for being with us, sir. Thank you so much for your support. Thank you for accepting our invitation, sir.
It's an honor. Thank you very much.
Dr. Abhijit will speak about distal radius fracture, a hand surgeon's perspective. Thank you so much, sir.
Thank you. Is my screen visible now?
Yes, sir.
So thank you very much for the opportunity, and it's an honor to be back here again with this August forum. And my task is to talk about distal radius fractures, approaches, tips, and tricks, a hand surgeon's perspective. So the hand surgeon's perspective basically refers to the soft tissue aspect and some nuances that we need to take into account when we talk about distal radius fractures. And I hope this will help our friends and colleagues who deal with these fractures. So this is the scope of the talk, wherein we will try to recognize fracture patterns that are unstable and those that require fixation. We will try and understand the classification systems and apply them, the approach and the anatomy, and understand implant design and indications, along with a few caveats. We'll start with this case in point wherein a young individual had this fracture. He had a fall onto an outstretched hand, was treated with this splint. And I think a lot of us would perhaps think it's okay to treat it this way. But this kind of went on to having 5 weeks later a displacement of this sort. And one would often wonder what went wrong during the treatment of this particular fracture. Did we miss something? So with that introduction, here is another case wherein you can see that there is quite some combination and collapse of the fragments of the distal radius here. There is also an involvement of the ulnar styloid fragment, styloid process. The lateral view also shows that there is combination and angulation, as well as shortening and displacement. And when we were discussing this case, some of us told that this is something which is still amenable to pins and casts. So just to kind of indulge and for resident teaching, we said, let's try distraction, and we got a reduction view under traction. You can see the traction being applied. The reduction looks reasonably good even in the lateral view. And then we put in a K wire And again, now it looks quite good on the anterior-posterior view. But then the moment we release the traction, there was a collapse again with displacement of the fragment. So we decided to fix this fracture, and we went ahead, opened up, removed that incarcerated bone, put in a plate, and got a stable reduction. So why are we talking about this? Because I think the fundamental goal of treatment for any distal radius fracture or any intra-articular fracture is articular congruency, to restore the anatomical alignment in terms of the length, inclination, and the tilt, to achieve and maintain a stable reduction with adequate fixation that will allow for early mobilization, and which in turn will allow for optimum function while minimizing complications. And when we talk about restoring anatomical reduction relationships when possible, we have to then take into consideration the three criteria, that is the length, the tilt, and the inclination. And that can be achieved through different modalities, right from close reduction and fixation to pinning and screws and plates, cast, fixators, and so on and so forth. What is important is that whatever modality we are using, we have to maintain the reduction until the fracture unites and prevent any late collapse. And for that, we need to understand the different fragments, and for which we need to have a good understanding of the anatomical, of the classification systems that are described in literature. So there are several classification systems that we are all aware of, right from eponymous classifications to those that have been recently described, and that includes the column classification. In our practice, we prefer to use the column classification simply because it is more practical and perhaps has the least inter and intra-observer variability in terms of identifying the fragments. So here is a fracture in three different views, and these arrows perhaps will help you correlate the different fragments quite consistently in the different views. So the column concept was described and propagated by Rickley and Regazzoni, and it forms the basis of what is called as a fragment-specific fixation in distal radius fractures, and has been expounded by different authors. Simplistically, there are three columns: the radial, the intermediate, and the ulnar column. Where it gets interesting is the subdivision of the columns. So the intermediate column is perhaps the most interesting aspect of the distal radius, where you have the dorsal wall, you have the volar rim, and you have the ulnar corner, which is again subdivided into dorsal and volar. And then you have the free intra-articular or incarcerated fragments with metaphyseal defects. And then, of course, the ulnar column, which involves ulnar fractures, which may be of the styloid or the articular surface or the head of the ulna. The concept is quite simple, wherein we aim at achieving a stable reduction of all columns and components. And it is advisable to start with the simplest technique and then advance these techniques as needed to address all fragments. So again, the principles for surgical treatment remain quite universally standard. Articular reduction can be achieved with percutaneous, arthroscopic, or open techniques. We attempt to restore all the parameters of the distal radius, and this can be achieved by different devices that have been described. For example, in the left upper corner of your screen, you have what is called as a tetrahedron variant of the distal radius, wherein there is only a fracture of the volar ulnar corner, and then this can very well be fixed with a plate that is specifically restricted to the ulnar corner of the distal radius. In this particular schematic diagram, you would now appreciate that there is a radial column fracture as well, which has been addressed by a separate plate on the styloid process aspect. A dorsal plate can be applied as required, and so on and so forth. So it's like building up a meccano and trying to address different fragments with different devices. Here is a case in point with a PA and a lateral view. You can appreciate the severe combination of the fragments. if you look very carefully at the posterior anterior view, we can see the ulnar column is absolutely intact, whereas the fractures involving the radial column and the intermediate column. And then we would now also appreciate that there is a combination of the dorsal rim, and these are fractures which are best studied with CT scans to gain further insight into what the anatomy of the fracture is like. And the CT scan would then also reveal the central depressed articular fragment. And these are reduced, and you can now see the intermediate column is being fixed with a plate, but this plate is not adequate to fix the radial column, in which case we use a separate implant to fix the radial column and achieve a good reduction which is stable and is adequate to hold this fixation till union while restoring all the parameters of the distal radius. Here is another case in point, and to the uninitiated eye, this may seem quite benign unless and until you pay attention to that little fragment in the ulnar corner, and that is the one that is going to play truant. So there is a fracture involving the dorsal as the volar cortices of the distal radius, along with this dorsal fragment, and then it's quite intuitive that it's very difficult to get a fixation or stability of this fragment through a volar plate screw alone, because you risk an intra-articular penetration in the radiocarpal as well as a distal radioulnar joint. So this fragment is especially important because it not only forms a part of the DRUJ, but also the radiocarpal joint. So again, a volar plate was used, and through a separate dorsal incision, that fragment was buttressed to achieve stability and good reduction of the distal radius. What about approaches and anatomy for these fractures? So we are all well versed with the volar approach. This is the Orbe approach, which is kind of a modification or an extension of the standard Henry approach, wherein we go through the flexor carpi radialis subsheath, and then you would identify the flexor pollicis longus as well as the median nerve, put it out of harm's way. And this stage, you would identify the pronator quadratus, which is coming into view right there. The distal aspect of the pronator quadratus is wherein what we have what is called as the watershed line. And then you have the entire distal radius from radial to lateral right in front of you. We like to elevate the pronator quadratus by sharp dissection in a reverse L-shaped manner. And then using alternate sharp and blunt dissection, we elevate the pronator quadratus all the way from radial to ulnar, so as to be able to suture it back to cover any hardware or implant that you may be using. One of the very important steps in good exposure and reduction of distal radius fractures is also the release of the brachioradialis that you need to do from time to time when you have these radial styloid fragments that are irreducible or maybe playing truant or difficult for reduction. So here is the approach wherein you have the entire distal radius in front of you for whatever surgery you would want to do. Here is a small trick that I would like to share with you all. Once you have reduced the once you have exposed the entire distal radius, there is a small cuff of tissue that you may want to elevate so that you can place your plate as far distal all the way up to the rim of the distal radius. And we'll just see that in a little bit in a video. Here is a video wherein you can see the importance of releasing the brachioradialis. This is a fracture wherein the radial styloid fragment was not being reduced. You can see the deforming forces of the brachioradialis onto the fragment there. And then as you dissect and as you elevate the tissue, this is the flap being elevated all the way from radial to ulnar. While we are preserving the distal insertion of the radiocarpal ligaments, it's very important not to destabilize the radiocarpal joint. And once you elevate that flap all the way from radial to ulnar, we'll see that in a subsequent slide how that helps in placing the plate you would elevate that flap and protect it and keep it out of harm's way. Another approach is the volar ulnar approach, which is especially important for your tetrahedron variant or the volar ulnar corner. This is between the palmaris longus and the flexor carpi ulnaris. And then in this particular approach, you just go between the ulnar neurovascular bundle and the palmaris longus, which is put out of harm's way. And then you can put in your plate and your implant to fix the tetrahedron variant. I'm just going to skip through this video in the interest of time. We have to understand the design of the plate, which is very important because it is very pertinent to understand the different plate designs which are meant for different fractures. We always talk about the watershed line. And here are two very commonly used implant designs. Here is your variable angle rim plate, and this is a standard plate. Why is this important is because, as I showed you in the previous video, if you're using this particular plate, it's not going to address this fragment or the distal fragment for the fracture which is distal to the watershed line. And should you cross the fracture fragment or the fracture line with this plate, the plate is going to be proud and cause flexor tendon irritation besides loss of fixation. And in this particular case, it is important to get your plate all the way as far as distal as possible. The hypodermic needle is where your radiocarpal joint is. And now you can see this plate that hugs the volar rim and gives you adequate fixation with your brachioradialis release as well as release of the flap that we just saw some time ago. There are different types of plates. I won't belabor too much on this because I'm sure that every one of you must be very well versed. Every conference you go to, you would find different designs and newer designs coming up. What is extremely important to know is that it is not the plate, but it is a surgeon that is important in getting the reduction and fixing it and maintaining it. There are indications of volar plating, contraindications that have been described in literature. What is very important, perhaps, that I would like to share is also to understand the role of your distal oblique band of the intraosseous membrane in maintaining DRUJ stability. A lot of times we find that if the proximal fragment remains medialized instead of lateralizing the distal, the proximal fragment, the oblique band remains lax, and that would still lead to DRUJ instability. So besides fixing the distal radius, it is important to also take into consideration the stability of the DRUJ in every distal radius fracture that we treat. And that raises the question of the case of the ulnar styloid fracture. Now, a lot of time, there is so much of debate about whether we need to fix the ulnar styloid fracture or not. To my mind, they do not always require, especially if the DRUJ is stable in supination. However, if it is unstable in supination as well as in neutral and pronation, so if you compare it to the other side, and if you have restored all the parameters of the distal radius, then it may very well be pertinent that the instability is because of the fracture and the THCC that is attached to the base of that particular fragment. Here's a case in point wherein we have fixed the distal radius fracture, and you can see with rotation the styloid fracture is falling off the distal ulna. Obviously, this is something that will require fixation. Here is a video to show how unstable the DRUJ is. We like to test it in all rotations. And then once we have established that the DRUJ is unstable, despite good fixation of the distal radius, we want to fix it. There are several ways to skin a cat. You can fix it with hook plates, with TBW. You can fix it with a suture anchor, as was done here, or you can even fix it with headless compression screw and so on and so forth. However, distal radius fractures, although being so common, everyone does it in every step of their career. There are certain caveats that we need to remember and we need to identify. And one of the most important aspects is the problem related with intra-articular hardware, inadequate fixation. And this usually happens when we fail to recognize the type of fracture and the implant design. Tendon irritation and ruptures are again very common, both flexors and extensors, malunions and infections, which are usually rare. Here is a case in point where you can see the tendon rupture because of a proud plate and a proud screw. Implants that are within the joints are not very uncommon. One easy way to determine whether your screws are proud on the dorsal aspect is to take what is called as a Hoya or the Dernick view and make sure that despite these x-rays looking good, the Hoya view will show that these screws are proud and they need to be revised. Here is a case in point wherein the distal radius fracture was fixed in this particular manner, and then it gives adequate stability. There are radiological nuances such as the teardrop and the anterior-posterior diameter of the distal radius. And if that is increased, this is a disaster waiting to happen in terms of displacement at a later time. And this is exactly what happened with our case when we started off. If you look very carefully at these measurements, we now realize why this fracture displaced at a later date. Complications of volar plates cannot be overemphasized. They have been described in literature, left, right, center, but we tend to neglect them. And I think one of the most important aspects that we neglect is the proud hardware that may cause tendon irritation. So Soong's grade has been used to identify the risk that may be imminent for tendon ruptures. Please bear that in mind. Do not use plates that are meant for dorsal to be used on the dorsal aspect on the volar side, on the volar aspect for the dorsal side, so on. So these are very common things and common mistakes that we see in clinical practice. Proud screws as well, and then there are caveats that have been published to avoid extensive tendon complications, which have been described. And again, these are just images to kind of not to mock our colleagues, but to kind of just help us understand that these are things which can be avoided and save our patients from disastrous outcomes. Very quickly, dorsal fixation of the distal radius fractures is something that a lot of young orthopedic surgeons shy away from, thinking that these are fraught with complications. However, in a properly selected patient with proper indications, these are very rewarding techniques, and we use a middle longitudinal incision. We go through the third extensor compartment subsheath where we identify and evacuate the hematoma. We elevate the third and the fourth extensor compartments sharply off the capsule, incise the capsule if required, and then reduce and fix. And often bone grafting may be required. It's a very quick video for you to indulge me while we very quickly go through this. This is a dorsal radius fracture. You can see the comminution that is present, and we use a middle. This is one surgery where soft tissue handling, soft tissue respect is extremely important. We elevate the flaps as full thickness skin flaps on either side of the incision, try and preserve the dorsal veins to the best of our ability, maximum possible preservation of the dorsal veins. And then as we go from superficial to deep, we identify the third extensor compartment, evacuate the hematoma, protect the tendon, keep it out of harm's way. Very sharply, we elevate the extensor compartments on either side of the third extensor compartment subperiosteally so as to expose the distal radius, release the brachioradialis if need be. And then a lot of times we find that there is a small window at the fracture site that can be used to elevate any incarcerated or impacted fragments using a freer elevator, just like so. Get in your bone graft whenever required to provide subchondral support, because a lot of times your implants are going to be used only in the buttress mode. So we have a very low threshold for using a bone graft. And then you bring in your implants. A lot of times you need different plates for the radial or the intermediate fragment. And then you can see that this is used in a buttress mode to reduce. Once your reduction has been achieved, you can then augment your fixation as required with a couple of plates more. The distal osteoarticular fragments that remain attached to the capsule can be sutured with non-absorbable braided suture, and these sutures can be passed through the plate and secured to provide additional fixation and stability to these particular fragments. We close the incision with covering the plates very carefully. And to date, to be very honest, we haven't had the necessity to remove any hardware for distal radius fractures treated from the dorsal approach. Very well covered plates and soft tissue handling that is appropriate will minimize the risk of tendon attrition and any complication that may be associated with the treatment of these fractures. So very quickly, in summary, we all know that distal radius fractures are very common. They will continue to challenge us in every walk of life and practice. We need to understand that our failures of fixation are what will help us improve our future successes. We need to very carefully assess the fractures to determine the optimal fixation, as well as understand and appreciate that each fracture is unique and should be treated as such, while remembering that it is a surgeon and his or her understanding of the fracture and how to fix it, and not the hardware, that will account for the outcome for our patients. So with that, I thank you for your attention, and if any questions, I'll be more than happy to answer them. Thank you very much.
Thank you so much, Professor Abhijit, for this very comprehensive presentation, and thank you for being for the second time with us. It's an honor for us, sir. Thank you.
It's an
so
honor.
much. Thank you. If we have any questions to Professor Abhijit. I think your presentation, sir, summarized all about the distal radial fractures. It was a very comprehensive presentation. Thank you so much, sir.
Thank you very much. Thank you.
Thank you, sir. Okay, sir, we can move to the next speaker, sir. The next speaker will be Professor Ashok Shivasshankar, will speak about a case of iatrogenic elbow instability. Thank you so much for being with us, sir.
Can you see my screen?
Not yet, sir.
Can you see me?
Not yet, sir.
No, it says my screen sharing has been paused. I do not know why.
Dr. Mina?
Because I'm not able to resume share.
Any technical problem with the Professor Ashok?
Professor, we are seeing that you have started screen sharing, but it is not clear.
It's not sure. Yes, sir. Yes, sir.
It started
it seems
now.
Can you make full screen, sir, please? Any technical problem, sir? Dr. Ashok? Can you hear me? Dr. Ashok, can you hear me?
We can see your presentation, a case of iatrogenic elbow instability.
Yes, but I think he is not hearing me. Professor Ashok?
Yeah, I think he's right now.
Dr. Ashok?
Please go back to a full presentation, PowerPoint presentation. It has gone to slide view.
I think he's not hearing us. Dr. Ashok? I think he's not with us now. I think he has a technical problem, sir. Okay, we can move to the last speaker. Tell Professor Ashok join again. Dr. Terence Jose Giroma will speak about acute compartment syndrome with a special focus on nerve recovery in children.
Thank you for this wonderful opportunity.
Thank you, sir. Thank you, sir. Yes, sir. We can see your presentation, sir.
I request all of you to call me Terence. I am Terence. That's it. Being the last presenter, this is something different in a concept which most of us are scared about, the nerve injuries. The moment we hear about nerve, we are a bit scared, as equal to the vascular injury. So these are my disclosures. Overall, we know that compartment syndromes or even Volkmann ischemic contractures, it's an orthopedic emergency. We know that it's an emergency. And we also been taught that these emergencies should be like immediately should be addressed because it might affect the limb and subsequent damages. Most common in upper limb is supracondylar humerus and femoral fractures in lower limb. So today the focus is on the can you see these pictures and videos?
Yes, we can see it, sir.
The pictures, can you see the pictures?
Yeah, I can see the picture. No, I can see the slides, but the pictures are not obvious on the.
Okay, just give me
on the left side.
Just give me a second. Just give me a second. Just give me a
okay.
second. Should I stop and start again?
Okay, okay, sir, no problem.
Sorry for the inconvenience, sir.
No problem at all, sir. No problem at all.
Technical issues are happening around, so. Can you see the pictures now?
Yes, sir. We can see it.
Okay. Yeah. Perfect. So the picture, can you see the picture now?
Yes.
Thank you so much. Sorry for that.
Thank you, sir.
The problem is, we see in upper limb in children, this is what exactly we see in an emergency room or in any emergency settings. Patients might come with some fractures, with pain and swelling and no motor deficit. Say, for example, this is a patient who came to us 6 days after the injury because it was properly not addressed or inadequately treated by the referral physician. Then what happens is we need to go on, do the compartment release, even though it is 6 days old injury, especially in children. And at the same time, we did neuralize both the nerves, the median and the radial nerve. So we expected by 6 days of the injury, we know that the wound might dehisce, and exactly what has happened. The wounds also started dehiscing. By the same time, the hand, which was completely paralyzed, started improving. So this was the range of movement we could get initially. But the wound also started healing. You could see a combined claw hand in this patient, which went into complete recovery of motor and sensory, approximately around 10 to 13 months for the sensory, and for the 7.5 months, the motor. So this was the final picture of the moment where the wound healed. And so you can see the movements there, the X-ray also united. So we always know that a 6 days old compartment syndrome, people and science article says that you should wait not to intervene. But interestingly, this is not the scenario which happens in children. That is the reason we also need to have the change or the paradigm change in understanding the compartment syndrome, especially in children following a fracture or following any other injury. Most common is the distal supracondylar fractures, which might cause a transient sort of compartment syndrome, and a pure brachial artery injury with fracture can also cause a compartment syndrome. So in a fracture alone with compartment syndrome, say this patient could not move her fingers because of an impending compartment syndrome. The family is also helping her. Ultimately, what we could do is we fixed the fracture, the pulse came back, and the child also did well with good range of movement. So these are all certain fractures which you need to fix them to get a good range of motion. Even at the time of injury, there's a huge swelling and no movement, or a pulseless pink hand. We understand as an orthopedic surgeon that in 4 hours' time, the muscle go into necrosis. But 8 hours' time, the nerve goes into permanent damage. And we also know that if we could decompress early, this prevents paralysis and contracture. How early? So now, I told you in the previous slide, we could do a decompression in a 6 days old compartment syndrome in children. But literature says that if you do more than 8 hours delay, you might land up in septicemia or you might land up in contractures, and you don't have any proper idea whether you should go or not to go. And this was the reason we had a thought. Thought is something like 6 days of presentation is not exactly 6 days. Why? Because we may not know when the compartment syndrome started. Injury might have happened somewhere 6 days back. Slowly it have gone to the compartment, and compartment syndrome could have started little later. It need not be 6 days. So any number of days patients present to us, we do not know when exactly the compartment syndrome started, when the compartment started to rise, and when this patient developed paralysis or a partial weakness. That is the reason we also need not believe that a delayed fasciotomy will cause infection or sepsis, will have a poor outcome, as it was believed in the past. And moreover, we also have that there is a possibility of collateral circulation, which can also help us to get good circulation. The entire scenario of our case series was based on one article, that is from Sundarraj from JBGS. They found almost in 196 patients, 55% had forearm fractures and 11 had supracondylar fractures. They retrospectively analyzed that all those patients who developed Oakman ischemic contractures did not have any surgery. So 196 patients did not have any surgery. Interestingly, they found the sensory recovery was possible in hand at 12 months, in forearm at 6 months. So no surgery, no intervention. They found that sensory recovery is possible even in this patient, meaning to say that nerve can regenerate and recover in the course of time. Also, we know that from literature, the muscle, even the smallest number of muscle, if it survives, it can regenerate even as late as 76 weeks of injury. So none of the authors or none of the compartment syndrome so-called specialists, they did not look into this aspect. That is the reason we found And also, you want to emphasize to the world that timing is not the indication for a compartment syndrome release. Why? Because we do not know when the compartment started. And without treatment, there is a possibility of sensory recovery. Why can't we go ahead and do to get motor recovery, even though the wound dehiscence may be a problem, as I've shown in one of the slides, initial slides there. So this is again another patient who had a injury who came to us 24 to 48 hours after the injury, good capillary refill, but the hand movement was not there. We know that there is a problem with the artery. We could do the primary anastomosis in this patient. The brachial artery was injured. We could do the primary anastomosis. The median nerve was bad. And we also know that because of 48 hours of injury, we know that the outcome is not good. The wound won't be so good because we repaired the artery there. And this was the flickering of movement which you see initially. Later, 1.5 months, what we could see is this patient slowly had a combined median and ulnar nerve claw hand. This was slowly recovering in this patient. You could see still he has a wound problem which healed ultimately, and there's a claw hand there and slowly improvement of acase. But 5 months time, the recovery was complete. This patient could do a complete range of movement, though the wound also healed well. But the problem of wound, dehiscence or problem of wound will not be there, especially in children, if you have that fear in this patient. So meaning to say that we intervene even if it was delayed, this patient is going to do well. Another patient of a fracture displaced 7-year-old girl had this fracture, and then we also had initially no movement there. Have got complete movement after we fixed the fracture, and this patient did well. So one patient we had 2 weeks of presentation. So this is the patient where a boy who was completely crying without no movement. You can see the limb completely swollen, a sort of complete established called compartment syndrome. And what exactly was that? He was always crying. He could have not any more motor movement, no sensory movement was also there. This was the fracture fixation. What we found was, once we do a complete debridement and we did decompress the compartments, we found the ulnar nerve was partially fixed with the Kirschner wire. On the contrary, the Kirschner wire was also passing through the supracondylar humerus and injuring the radial and the median nerve. So all these 3 nerves were injured, and the compartment got also infected. So we could do completely thorough debridement, could change the orientation of Kirschner wire, and we know that this wound is not going to be good. Though it looks good, it will not be good in the postoperative time. So we expected the wound to be little superficial necrosis. Again, we put them on stimulation. We healed well. The ulnar nerve started to improving. The median nerve also started improving. We put them on therapy there. And then finally, this patient had this range of movement. Again, a 5-year-old boy who had a compartment syndrome. We fixed the fracture, and then he had a slowly recovering ulnar nerve, which also recovered in the course of time. Another interesting is the 7-year-old boy who had this brachial artery injury there. You can see the brachial artery injury is completely there, and the median nerve was also injured there. We could repair, fix, but immediately what happened is this patient did not have the median nerve recovery. And this is the video of the time 6 weeks you will see, and at 6 weeks, this is the range of movement of this child. And this patient also had some skin grafting done by other plastic surgeon in the elbow. Ultimately, what happens, this is the presentation at 12 weeks. Again, he had a high median nerve palsy. The median nerve did not recover. Do not worry about this, because we know that compartment syndrome will take some time for the motor to recover. And this was a 10 years follow-up. This patient had completely recovered the median nerve, and this patient had good FPL function and other function. You can see the scar there, just still lying there. It just came for a scar revision. I said we'll do somewhere in the school holidays. So such is the great potential of the nerve, especially if you see compartment syndrome, which has the potential for the nerve to regenerate the neuromuscular junction and get the muscle working. So don't think that muscle will not regenerate, especially in children of this kind. So what made us is that we have published this entire series as acute compartment syndrome, especially with the special focus on nerve surgery. This one published in one of the BMG journals. So what we found in our study was that the average time to surgery was approximately 44 hours. So many say that more than 8 hours don't operate. No, we don't follow that because we do not know when the compartment syndrome started. So in our series of 24 patients, we found that nothing contributed much to the outcome, especially the gender and all these things. But if they have supracondylar humerus fracture with artery injury or delay for 24 hours, they may have a bad outcome if they don't properly treat. And all those patients had radial, median, and ulnar nerve injury, and they recovered approximately from 6 to 8.5 months. Sensory recovery, as you know, that it was completely recovered in almost 10 to 13 months in our series. So to conclude, there is a possibility of motor and sensory recovery in patients with acute compartment syndrome, irrespective of time of delay in presentation. You go and intervene, give the nerves to, allow to breathe, get the muscle to work, and definitely you're going to get a good functional effect, especially in children. The motor and the nerve fibers can regenerate after the ischemic sequelae is being taken care of. Thank you so much for this wonderful opportunity. I thank our Indian contingent and also the Egyptian contingents for this wonderful opportunity of educational forum. Thank you so much. And I being the last speaker, I think so patient enough to be here, especially at this time. Thank you so much.
Thank you so much, Dr. Terence, for this very interesting case presentation. And thank you so much for being patient with us. So you are the last speaker, but as we said, the best is the last. Thank you so much, sir. Thank you so much, sir. If we have any questions to Dr. Terence. Okay, I think we have no questions, sir. Finally, I would like to thank all our Indian colleagues and our Indian professors and speakers for joining us in this very fruitful scientific webinar. Your participation makes us very honorable participation. Thank you so much for being all with us in this very fruitful webinar. Thank you so much, sir.
Thank you.
Now we will thank you. Thank you so much. Thank you, sir. Thank you so much, sir. And to all our colleagues. Thank you so much, sir. Have a nice time. Thank you so much, sir. Now we will move. If you would like to stay with us, we still have 4 hours in the webinar session.
It's almost 12 o'clock in the midnight, so I probably go.
We will finish at 2 a.m., sir. 2 a.m. Cairo local time. Thank you so much, sir.